morning, good morning. Happy Monday. I know those two words do not go together, do they? What's that? I gotta go somewhere. Everybody's so late and I'm already feels up. Well, now it's too late. It's dinner time. Then we gotta relax.
Practice feeding.
Oh, that's right, girl.
I get practice every day over there. I have these patients and they're like, they just throw their hands up and they're going like this. And I'm going, oh boy, here we go.
Oh, man.
And then I have one that just wants to eat everything and anything. Goes around and picks up stuff up on people's plates. And I'm like, oh my God. I was like, you have your own food. I don't want that. I want what she, you're having the same thing that what she has.
Anybody have any questions over what you did over the weekend? You guys had 8 and 9 over the weekend. Yeah, any questions on either one of those? Chapter 8 is a little bit challenging because it goes over nutrition. It doesn't go very deep into nutrition, but it does go over nutrition. And it has some special diets in there. The biggest thing that you need to understand about special diets is that we really are what we eat. So if you have a patient that has a low salt diet and you give them a regular tray, there's going to be health consequences to that later on. So our main priority here is to make sure that we're giving the right patients the right trays. And if you notice that you're not, like you passed all the trays and you realize, oh my gosh, I gave Mr. Hopkins the wrong tray, you need to go get that tray. Now, don't just say, oh, well, because there's going to be health consequences for that.
I have a patient that has like thickening. And we have, sometimes we do oatmeal and then when another LPN comes in, she's like, no, you can't give her that. I was told I could. Because we have to water it down.
Okay. Again, I can't give you specifics about, that there may be something about that patient beyond what you know.
Right.
That the LPN is telling you not to give them. I don't know. I can't remark on that.
I can give her mashed potatoes and gravy, but I just can't. I was like, this is just too.
But again, I don't know all of the situation there. Maybe, I don't know. I can give you a million possibilities, but that doesn't help you.
Right.
Your job is to follow whatever the nurse says, even if it doesn't make sense to you. Because
I see her on other days she's eating it.
Okay.
So I'm just like, this is weird to me. But if there's somebody else giving it to her, it's fine. But when I get it, she's like, oh, maybe. I think she's just nitpicking.
Again, I can't remark on that. But what I'm trying to get you to see is your perception may be off. Okay. Because if it's a situation where it's only you not able to give her oatmeal, maybe the nurse feels that you specifically are watering the oatmeal down too much. I don't know. If it's another nurse that says she can have oatmeal, but this nurse says she can't, that's a different situation. If it's flavored oatmeal versus plain oatmeal, that's a different situation. So you're asking for an answer when there are 48 billion variables.
Right.
And I can't answer that. I don't know. But what I'm telling you is that as a CNA, you do not have the full picture.
Right.
There's all kinds of information here that you don't know. So it doesn't make sense to you from your point of view because you don't have the whole story. Okay. So a good analogy to this is if you go next door to a movie theater and you walk into a movie 45 minutes after it started and you sit down for 5 minutes and then get up and leave, and I ask you, what was the movie about? You're just going to be able to tell me that little tiny part that you saw. You don't know anything that came before. You don't know anything that came after. You have no idea how the movie ends. All you know is that little 5 minutes right in the middle that you happen to see. Now, things are not everything is, you may be able to kind of figure out like the main plot of the movie in that 5 minutes, possibly. But there's going to be little details that happen that you're not going to have any idea why those details happen. It doesn't make any sense to you. So that's kind of the hard part about being a CNA is because you are literally watching 5 minutes of a Lifetime movie. And you might be able to figure out the big plot lines, but you didn't get to read the script, right? You didn't even get to read a report on the movie. I mean, all you have is that little 5 minute sliver. And it's often hard to make sense of everything that you're seeing and hearing and experiencing with that patient, just because you don't have all of the information. The problem is that sometimes we try to draw conclusions or correlations with our limited information. And that's where we get into trouble. Does that make sense? So I can't, when it's coming to oatmeal, I mean, there's a million questions I would be asking here. I don't know. And it could just be as simple as one nurse thinks that oatmeal is fine for this patient. Another nurse thinks that oatmeal is not fine for this patient. That could be. Nurses sometimes have a difference of opinion, a differing care plan. But this is why the care plan is supposed to direct all staff members. Okay, not just CNAs. The care plan directs all staff members. Yeah. And it could just say thickened liquids. I mean, that's a possibility. Care plan may just say thickened liquids. Well, oatmeal is not a liquid. It doesn't need to be thickened, but you can make oatmeal very, very runny by putting liquids in it. But this patient, all liquids need to be thickened, right? So if we're adding liquid to the oatmeal, then maybe it needs to be a thicker consistency. Okay, so I can't give you the one answer that you're looking for there. Yeah, but the big issue here is to make sure that we're following the care plan, that we understand that we don't know the big picture in all of this, and that we don't make decisions when we have incomplete information. And that's probably the hardest job I have in here, is to keep you from thinking, because you want to think. You do. You want to reason things out. You want to put things together. You want to know 1 + 2 = 3. You're trying to make those correlations, but those correlations are not always spot on. Does that make sense? But the big thing to take out of chapter 8 is I want you to know that different conditions get treated through diet. Has anybody ever gone to the movies and gotten popcorn?
Yeah.
I know, movie theater popcorn is the best. The best. Yeah. Totally. Yeah, totally. Oh yeah, Disney. But totally different than what you throw in your own microwave at home. Right? That's just, there's no comparison there. Right? Movie theater popcorn is good. But when you eat popcorn, especially at the movie theater, you usually have to order it with a jumbo sized drink, right? They come prepackaged. Right, right. So that's because when we eat the popcorn, it tends to make us what? Dry, thirsty, right? So let me explain to you why. Not that you need to know, but this is interesting. Okay. So when you eat salt, like high sodium things, do you remember we talked about diabetes a while ago and we learned that sugar can't be excreted, so whatever's extra remains in the bloodstream and just circulates around and then ends up coating the inside of the arteries, the nerves, all this stuff, right? You guys remember that? Because you can't get rid of it. You either have to use it or store it, or it just settles, but you can't get rid of it. Salt is also a crystal like that. So when you take in salt, your body can't, it's very difficult for your body to get rid of salt. It can, but it's very, very, very difficult, very hard. So the only choice that your body has when you take in a lot of salt is to dilute that salt. That's it. That's its only choice. So how would we dilute a salty bloodstream? Well, you have water in your tissues. Like, you know, we got excess water. You know, you're a little squishy, right? Little excess water in your tissues, that's a good thing. But when you eat too much salt and we have an overload of salt inside the blood vessels, the body says, uh-oh, we got to dilute that. So we are going to take water out of the tissues and put it into the bloodstream. We're also going to tell the kidneys, hey, don't pee so much. Don't get rid of all of our fluid. So you end up with blood vessels that had a lot of salt in it. Now we are diluting it with a lot of water. So what happens to the volume inside, the amount of fluid inside your blood vessels if we're adding more fluid in? Okay, we got more fluid. What do you think that does to your blood pressure? That's right. That's right. So people that have high blood pressure are going to be on a low salt diet. Does that make sense? So if you give this person pretzels and you take their blood pressure 2 hours later, and then you go to the nurse and go, oh my gosh, they have high blood pressure. And the nurse says, well, what did you give them for a snack? And you say, pretzels. So we have to know a little bit about nutrition because we often provide meals and snacks to patients. So we need to understand that what we eat has an effect on our health, but also what we choose for the patient will have an effect on their health. So if we have somebody who has osteoporosis, which leaches calcium out of the bones, so the bones end up looking like Swiss cheese and they're really, really easy to break. So if we have somebody that has osteoporosis and their diet order says increase calcium, and you're choosing a snack for them, which of the following would be an appropriate snack for this patient? A, sugar-free Jell-O, B, yogurt, C, pretzels, or D, caramel popcorn? Yogurt. That would be an appropriate test question. Okay. Does that make sense? Okay, so chapter 8, not too terribly difficult. I mean, it's kind of a shorter chapter, but you do need to have that awareness that diet does impact health. Okay, chapter 9 was on rehabilitation. There's 3 types of nursing, and you need to kind of be aware of these 3 overall types. There's actually way more, but I'm kind of condensing it into 3 main types. Okay, There's rehabilitative. That means that we're trying really hard to make somebody better. Now, rehabilitative is probably what you guys are most used to. You break a leg, you go to the hospital, you have surgery, you go to physical therapy. That's rehabilitative care, right? That you have a problem, they're going to make it better. Then there's restorative care. Now, restorative is kind of a step beyond that, right? Because rehabilitative, like if you broke your leg when you were 12, you're not still receiving treatment for that, right? This treatment was kind of short term, just to get you over that immediate problem. Rehabilitative is short term. Restorative is more longer term. Restorative means that you broke your leg when you were 12, so you have therapy. You did everything you were supposed to do when you were 12, but now that you're 22, you want to make sure that you're keeping those muscles in good shape to keep, everything in the right place. So your ongoing treatment plan is to maybe walk a mile a day, something like that. So rehabilitative is to correct the initial problem. Restorative is to kind of maintain the progress we make. Okay. And then there's custodial. Now, custodial means that the patient had a problem. The patient maintained whatever treatment there was, but things progressed and they're just kind of at a point now that we're not trying to make them better. We're not even trying to keep what we accomplished going. We're just trying to kind of maintain their current level. We're trying to keep it from getting much worse, or if we know it's going to get worse, to try to support them in that journey. So custodial care is more, we're kind of doing most everything for the patients, because we're not trying to get them better. We're not trying to restore independence. We're just trying to keep them cared for. Okay. So rehabilitative is the one that we most think of when we're young, because that's the type of care that we've most received in our life. Restorative care is going to happen usually in rehabs, long-term care facilities. So rehabs are going to do the initial rehabilitative, but they're going to transition by the time the patient leaves into restorative. They're going to teach the patient how to keep up with their current level of health. And then that slides into long-term care. So if you go to work in a nursing home, you may be a restorative aide. That's a term that you'll hear. Long-term care also has custodial care for those that have progressed beyond that point. Okay. So 3 main types of nursing, and you need to be aware of that, because we don't always provide care aimed at getting somebody better. Now that's your experience though. So your mind is always going to be prone, right? Because that's your experience. Your mind is always going to be prone to, come on in, hi. What are we doing to make this patient better? Or, I'm performing this task to make the patient better. Do you guys remember learning range of motion? Were we doing exercises to make somebody better? Think about range of motion. What was it? Maintaining. Remember, range of motion, physical therapy regains, CNAs retain. So, but your brain automatically tried to make that. I'm making them better. Okay. Remember that everything we do in medicine is not always aimed at making people better. Sometimes our care is aimed at keeping what we've got And other times care is going to be geared toward making patients comfortable as they decline. There's different stages. And you're probably not going to be familiar with that because your experience is that we tend to do things to make people better. So when you see things on the care plan, it may confuse you. If your mind is thinking, we're here to make people better, right? And you see something on the care plan like, this patient can't have oatmeal. Your brain is probably going, well, how does that make them better? It may not. It may have nothing to do with making them better. It may have everything to do with keeping them at their current level of care or to support them as they decline. Remember, there's two totally other types of nursing beyond what we are familiar with. So you kind of have to have that in the back of your mind. And this is where that care plan becomes so important because you as a CNA are not going to have any clue what area of your patient's journey they're in. Okay, does that kind of make sense? You're starting to see that nursing is very, very complex. It's a whole lot more than giving pills and starting IVs. That's the part of nursing we see. But there's so much more to nursing that you can't see because it's all happening here, invisible. But that's where that care plan is going to come in. So the nurse is going to take all of this information and develop a care plan that's going to tell you what to do. Your entire job is to follow that care plan because there's a reason behind every single aspect of it. You don't necessarily need to know the reason, but we do have to follow it because somebody somewhere has put some thought into this and decided that that action is not a good one for this patient for whatever reason. Okay. Good. Anybody here familiar with Nurse Blake? Anybody ever hear of Nurse Blake? Nurse Blake is a young man. He's absolutely adorable. And he is a nurse, a real live RN. He works here in Florida, but he actually is a national comedian. Okay. But his audience is all healthcare workers. So he makes fun of nursing and nursing school and nursing standards and care plans and shift reports and all the things that we find humor in medicine. And like I said, he's absolutely adorable. He has, he sells to, you know, he does like comedy things where, yeah, I mean, he fills stadiums. He has cruises that you can go on and listen to Nurse Blake and have a great time. And I listen to him a lot. I find him very, very entertaining. But he put out a video last week and he does like little shorts, like just little short skits, right? And he put out, it was maybe 20 seconds. And it's when your fall risk patient tries to get out of bed and he's, you know, trying everything to get them back into bed, you know, just, it was very, very cute, but we have it very entertaining, but we have to understand that if we know anything about fall risk, we know that keeping a patient in bed does not improve their outcome, does it? It makes them weaker. So if you have a fall risk patient that's trying to get out of bed, it's probably a good idea to help them with whatever it is they're trying to do, not entice them to get back into bed where they're not going to stay anyway, right? So it was a very cute skit, but it sent the wrong message. because it got a whole bunch of nurses to think about them, not the patient. And that's one of the big risks in medicine, is that it's really easy to slip back into that. It's all about me. You know, I don't want you out of bed because you're a fall risk. I don't want you to fall because I don't want to do the work. It's all about me. So although entertaining, it may not be the right message that we want to be sending. So just be careful about the types of content that you access, especially before you go take the test. Okay. And you guys will probably start seeing Nurse Blake on your Facebook feeds and Instagram and everything, because you're in healthcare. And he is the one thing that the boy is very good at is marketing. Marketing. So if you've got anywhere on your feed that you're going to CNA school or anything, you'll start picking up Nurse Blake.
Started seeing like CNA TikToks. Honestly, that's probably what I think is familiar from.
Yep.
Because I like TikTok.
Yeah, and he's big now on TikTok. He started out on Instagram, but he's real big on TikTok. And like I said, you know, a lot of the stuff that he does, you know, I find very entertaining. He's adorable. And he does work here as a nurse in Orlando. And I have a lot of respect for what he's done for the industry. He's really, really big on trying to push safe staffing. And I think that that's a very good thing. But it just shows us how easy it is to revert back into that. It's about me, not the patient. And you'll do it without even thinking about it. So I want you to remember, at the end of the day, above everything else, you have to ask yourself, is this about the patient? When you're taking the test, that's what they're going to be deciding. Can you make it about the patient? So keep that in mind when you're making decisions about the answers you're going to choose on the state exam. The one answer that makes it about the patient is going to be your right answer. Okay, does that make sense? That's the best advice I can give you. All right, Tina, how'd you do?
I was 2 on 8 and 1 on 9.
Thank you.
Yeah, I got one actually turned around.
Oh, and that makes you, yeah, makes you miss 2 on the matching. Yeah, Marissa. Sure, no problem. Rebecca,
7 on this one and chapter 8 on it.
I need 8 and 9. Do you have 9?
Yes. -2 on 9.
Thank you. Christine,
I got 108. This one.
thank you. Dilcia,
1 and 8 and 1 and 9.
thank you. Jillian, Melcora,
1 and 8.
I'm not done.
that's fine. Caitlin,
So great.
okay. Marissa, you ready?
I missed 1 on 9.
Okay.
And I missed 1 on 8.
Okay, thank you. Alexandra? Should I call everybody? I got a lot of scratch offs on here. We started out with 13 and we're now down to not 13.
7.
Yeah, so we've lost a few. So you guys have chapter 10 tonight. Chapter 10 is super quick. It's a short chapter. It's on stress management and employability. So not a hard chapter at all. Pretty easy. Yeah. We'll be talking about that a little bit on Wednesday as well on graduation. But I don't go over everything. So even though it is an easy chapter, I do want you to read it because I'm not going to go over everything in that chapter in our discussion. So make sure you read that. And then I will be collecting your books on Wednesday. So please bring your blue books back. And once you've read it, you'll never refer back to this book again. It's just going to end up a big paperweight somewhere. So if you did not do the reading and you're concerned, you can purchase the book, but my suggestion is to purchase it from Amazon, not me, because I'm going to charge you $42 for it. You can get it for $20 on Amazon. So go to
I
Amazon.
would just like read it over and over. 'Cause it puts the information into my mind, into my memory bank.
Yeah.
Real good, so that's what I'm doing.
Yeah, and that's very good. And if you want the book to be able to refer back to before testing, I mean, you may feel that that's a good purchase for you. But for the most part, once you've read this book, you're probably not going to need it. This book covers theory. We cover theory in class as well. But there's 5 things that I want you to remember when you're taking the written test. And that's really, I'm going to sum this blue book up into 5 main categories. Okay. So the written test is going to grade you on knowing your role. Now, we've talked a lot about that in this class. A lot. CNAs follow the, okay, so we don't change it.
No.
We don't think, do we?
No.
Okay, while we're following the care plan and we notice something, what do we do with that information? Tell the nurse, right? So we're going to report everything to the nurse. That is your role. So knowing those 2 pieces of information, okay, we follow the care plan, the whole care plan, nothing but the care plan, we don't think. And we report everything to the nurse that we notice that's abnormal, right? So that brings me to number 2. So if we're reporting abnormals, then that means that we have to know normal, right? So we need to know our normals. That's number 2. And normal goes beyond vital signs. Yes, we've learned normal vital signs. We know a normal pulse is between 60 and 100. We know normal respirations is between 12 and 20. We know normal blood pressure top number is between 100 and 119. That's your systolic. Bottom number is between 60 and 79. That's your diastolic. So yes, we know normals, and we know normal body temperature is about 98.6 degree either side is fine, but right around 98.6. So we've learned that in class, right? So yeah, we know our normal vital signs, but it goes beyond that. When we talk about knowing normals, we also have to know what's normal for aging skin. Do you remember we talked about we lose something as we age with our skin? Anybody remember? What is it? Layers of fat. That's right. What does that fat do? Insulates. Keeps your body heat in, keeps the outside temperatures from affecting you. It also protects your underneath organs, you know, your blood vessels and things like that from injury, right? So is it normal for patients that are elderly to feel temperature different from you? Okay, what do we know about normals with energy? What happens to your energy as you age? Yeah, it decreases. What about your strength? Decreases. Muscle mass decreases. Ability to eat large meals decreases. Okay, so we have to know what's normal with the aging process. So the first thing is understand your role. The second thing is know normals, because remember, part of our role is reporting abnormal, right? Okay, number 3 is never treat an adult like a child. We don't call them bibs or diapers. when we're using things with adults, right? We don't treat adults like children. We don't make them say please and thank you. We don't teach them manners. We don't punish them. We don't restrict them. We don't keep them from doing adult things they want to do. They're adults, right? You're going to have at least 2 questions on that state exam that is trying to see if you're going to treat an adult like a child. So I want my voice in your brain on testing day saying, do not treat an adult like a child. Okay, so know your role, know your normals, don't treat adults like children. Now, we also have to understand safety. So safety is both the patient's safety and your safety. So where does the patient need to be in the bed at all times? In the middle. Does it matter whether on their back or their side? No. It doesn't matter if they're in bed, they have to be in the middle of the bed. Well, if you are turning somebody, and we know that they have to be in the middle of the bed, right? When you are rolling somebody, what's the step you have to take before you roll them? Scoot towards you. That way, after the roll, they're in the middle of the bed. So patients always have to be in the middle, right? Beds always have to be in the, what position? Up, down, lowest position. And can we use side rails to keep our patients safe? No. That's right, not unless there's a doctor's order. If the patient's feet hit the floor, we're going to talk about their shoes, right? We have to have shoes on when we walk. Why aren't slipper socks enough? Okay, they slide. Do they protect against pathogens? Do they protect against sharps? Would you let your children walk on that floor? Put shoes on them. That's safety. When you're lifting a patient up, we have to use the right body mechanics to stand somebody. Do we stand right in front of them when we lift them? No, you have to stand at an angle. How do we know a gait belt is tight enough? 4 fingers. What happens if it's not tight enough? Okay, so you got to adjust it and make it tight enough, but what? Yeah, as you lift the belt, patient's gonna slide right through it. It's not gonna lift the patient, it's gonna lift the belt. That's a problem. When you get a patient standing up, can we just like go? Okay. All right, so give them a minute. Give them a minute. Let them acclimate, make sure they're not dizzy, nothing's going on, and then we can walk them. While we're walking them though, should we maybe check on them once?
We have to ask him if you're busy or something.
Okay, all right. We're going to ask, what else can we do to see if they're doing okay?
We can watch if he is sweating or looks like pain.
Okay, very good. You're going to use your eyes too. So we're going to watch for pale, sweaty, slowing down, reaching out for support, reaching here or here, getting a little wobbly. Anything we see that's like, that's not right.
Shaking. I learned with my husband because he started to shake.
Yes, that's a very good sign.
I know a lot of things about it.
Yeah.
Because all the time I'm asking him, are you happy? He said, no, I feel strong, but I feel like.
Yes.
And he was shaking and I said, no, you know.
Yeah, your patients will absolutely lie to you. And I can attest to that because I lied to my husband this morning.
Why?
Yeah. No, I told a big fat black lie. I mean, it's out there, right? So I've got a problem with my knee and he's worried about me and I don't want to go to the doctor. So I told him, no, it's fine. I told him that yesterday, no, it's fine. It's fine. We took my, a whole big group, but my granddaughter's 6th birthday was yesterday. So we went to the aquarium in Tampa and I walked. And then I walked my dog about 1.5 miles every night. And then I get into the pool and I do exercises because I've got this knee problem and I'm trying to overcome it. And I'm stubborn. And he's watching me limp through the house. And I'm like, no, I'm fine. It's better. It popped back in place. Everything is good. This morning, my knee now has, if you put your hand on it, when I bend it, it feels like broken glass in there. You can actually feel it. So I know I got a problem. I know it's going to have to be addressed, but I flat out lied to my husband. Oh, it's fine. It's good. Everything's fine. I'm like, so will your patients lie to you? Absolutely. You need to pay attention to what you see as well as what you hear, because they may not match up. Okay.
You gotta be careful with that. You gotta blow your knee out. You're gonna be walking soon. If you keep it up.
I have a knee brace on order. I'm just waiting. I'm just waiting. No, I do have a doctor's appointment in 3 weeks. So I couldn't get one any sooner. So I did break down and make an appointment, but
Hopefully your knee makes it.
yeah, it'll be fine. It's fine. It's fine. Yeah, well, I think that's part of the problem because
All the swimming and stuff.
no, it was the stairs. My husband is very physically fit. I mean, very. And he's outside working all day. I am on a computer sitting on my tuffet, you know? So he is way in way better shape. Well, when we go on a cruise, he doesn't think anything about climbing 9 flights of stairs. And I'm like, after the second one, I'm like, I'm trying, but I don't want him to know that. So I just hold on to the rail and pull myself up. Right. So I must have done probably about 40 flights of stairs on the cruise, and not all at once, of course, but I don't think my knee liked it. And ever since I got off that cruise, it's like getting worse.
Personally, I have knee problems and I have to stop getting the stairs somewhere at the gym because it feels like it's grinding.
Yes.
It's like go up steps.
Yeah.
Like I can't.
Yeah, it's interesting. But anyway, enough about me. I'm just telling you, your patients will lie to you. They will lie. So watch what watch what their body is telling you, not necessarily their mouth. Because yeah, that your husband is telling you he doesn't have pain, but that shaking is telling you a different story. Okay. What effect do you think pain has on blood pressure? Raises it. That's right. So because it's a response of the body that we're going to restrict the blood vessels to put blood in the middle of our body, protecting our vital organs. Because pain means something is wrong, right? So I got to keep my heart, liver, kidneys, all that working. I can sacrifice the extremities, that's fine. So your blood vessels tend to constrict, to push blood to the middle of your body. Okay, that constriction causes the pressure inside to go up. So if we have somebody who has pain and they're not really admitting to the pain, the blood pressure may tell us a different story. Now, even though the patient may be like, I'm fine, everything's good here, nothing to see, right? That may be having a negative effect inside the body that the patient isn't even aware of. So this is why we have to listen to what our patients are saying and what they're showing, because it may be doing damage that your patient doesn't even know is happening. And I'm aware. Yes, thank you. I'm aware. But it's good to have that understanding, right? So we're going to report all of our observations. So we have to know our role. We have to know normals. We have to protect their rights, right? Don't treat adults like children. And we have to promote safety, even from the patient themselves. Okay. So the last thing is probably the most important out of all of that. Now that's a lot of important stuff, But the last one is probably the most important, and that is understanding infection control. Because remember, your patient is a patient. They're undergoing something. Their immune system is currently busy. Like my immune system is all right here. I can tell you because it's swollen. That's where all of my immune system is concentrated. That's what swelling is. That's what swelling is. It's all of your body's white blood cells that go, oh, problem, sector 3, I'm on it. And they all go there. Well, it's like a concert, right? You get a lot of people in one place. There's a lot of people, right? So here I've got some swelling because there's a lot of white blood cells in the area. So I know my immune system is currently busy. It's occupied. Now, if somebody were to bring me a new pathogen, is my body going to be able to fight it off? Maybe not, because remember, my white blood cells are currently working. So infection control is probably the biggest factor in successful healthcare, because we're going to try real hard to help our patient through whatever it is they're currently dealing with. But while we're doing that, we want to be careful not to give them a new problem to have to worry about as well. Good. Anybody ever shop at Sam's? Anybody shop at Sam's? All right, so here's a homework assignment. Next time you go to Sam's, go to the food court and hang out and watch the workers. Watch the workers. They have gloves on because they're getting your hot dogs and your pizza and your churros and all of that, right? I want you to pay attention to the other things they touch without even being aware of it. The cash register. Yeah, I went to Sam's on Saturday. So cash register, that's kind of a given. The container to the hot dog bath, right? That's a given.
Get out of bun, don't change, don't take them off.
Okay.
Get out of bun, put it in the paper.
Right.
So you gotta
And that-
mention all that.
That's okay. Those items are pretty clean. And here's the problem. When they take that last bun out and now they have an empty plastic bun wrapper package, right? Where does that's trash. So where does it go? And the garbage has a lid on it. So what do they have to touch? The lid to the garbage to throw it away. Yeah, absolutely. Absolutely. So what are some things that we as healthcare workers can learn from that? I mean, do we wear gloves too?
Not all the time.
Not all the time, right? We're going to wear them when it's appropriate, but we do wear them. So if somebody in food service is doing this, what's a lesson that we can learn from that? Okay, be aware of what we're touching. Absolutely. Absolutely. From a food standpoint, just standing in line at Sam's. Now, I don't let this really get to me because I've got a good functioning immune system. I'm going to eat my hot dog. Yeah, I'm going to eat my hot dog. It's fine. I don't get too tied up in this, but I do like to use it for illustration. So just standing there, because I do food safety as well. Okay, so I understand that I wrote the program for the standards for food safety for food service workers. So just standing there, there were 3 people in front of me. So I stayed there for a little bit, right? But just standing there, I counted 14 violations before I stopped. Okay. I still ate my hot dog, but it happens. Now, why do you think it happens? Do you think they want to do that? Do you think that they, got up in the morning, they're like, I'm going to touch as much stuff as I can, right? Do you think they want to do that? So why is it happening, do you think? Okay, so part of it just may be strict ignorance. They just don't know any better. That could be. Okay, so somebody else trained them and said, oh, it's fine, right? Maybe it's because they're not really thinking about it, right? They're not paying attention. They're focused on their task, not infection control. Do you think that those situations, right? Learning from somebody else, not being aware of the standards and not paying attention, do you think that might apply to healthcare workers too?
Yes.
Do you think that we're at risk for that? So that's why I bring this to your attention. Just because you know something doesn't mean you're going to apply it. Because when you're out there, you might get focused on the task rather than the process. Does that make sense? Okay, so the state test realizes this. And that means that you're going to have quite a few questions on the state exam about infection control. So I want you to really understand it. So let's go back to our 5 things. Know your role, know normals, patient rights, don't treat adults like children, safety, both yours and the patient's, and infection control. Those are the 5 things that blue book covers. Those are the 5 things that are going to be on the state exam. Now, you guys have just proven to me that you know these 5 things, so you don't need that book. Good? Does that help you guys? The written test is not going to be hard for you. You've made it this far. Okay? Out of 13, I've got 7 of you left. Made it to this point. That written test is not going to be hard. Where I want you to focus your time and energy is on the skills. The skills are a little bit harder because you've got to demonstrate. You have to do. And you know during the test that you got 2 RNs watching you, and that's not a good feeling. It is nerve-wracking. I do this for a living, right? I can do these skills literally with my eyes closed. I wrote the book that's being used everywhere. Everywhere. I picked up 5 new schools this week. Everywhere. And those evaluators that are watching you, that are grading you, their training program uses my videos. Did you get that? So they are trained to grade you using the same processes that you're being trained to do. Okay? So I'm very good at what I do. But if you put me in that testing center and told me I'm going to grade you, I would probably lose my mind. Because now I'm being judged. And nobody likes to be judged. So I get it. I understand. And those evaluators get it too. They expect you to be nervous. They're not looking for how smooth you are. It doesn't have to be pretty, guys. It does not have to be pretty. You can and your way through the skill. No problem. But they're not focused on you. During the test, they're focused on the patient. So they're looking at how safe is that patient? How much does the patient understand what you're about to do? Is that patient exposed? Does that patient look comfortable? Is that patient safe? That's what they're focused on. Every one of those checkpoints has everything to do with the patient, not you. Okay. And if you can remember that during the test, it's not about me. It's not about me. It's not about me. Spotlight is not on me. It's not about me. It's about the patient. If you can make that one small change in your mind and you focus on that patient where the evaluators are focusing, you'll do fine. Okay. But it's hard to do because you're being tested, and I get it. But the good news is you can make corrections. That's good news.
My question is, when I check my care plan, if I know I did something wrong, how I can correct? Start over or what?
You can start over, yes. You can. Who should we be talking to during the test? The patient. So you can tell the patient, oh my gosh, I have lost my mind today. I'm just going to start over, okay? Because I just think we would do better if we just started over. So I'm just going to put this stuff away. Let me start over. Hold on. Okay. I would do that in a clinical setting. Guys, there are days that my mind is no longer in my body. Okay. And I have done that with patients. Oh my gosh, what am I doing? Hold on, let's reset here. Hold on. My name is Patty. I'm your nurse today, and I'm here. It's perfectly okay. We've all had those days. It's okay. So yeah, you could start over. But where do those evaluators want to be?
At home, by the pool.
Uh-huh. Do you think they really want to hear you start over?
No.
No. So yes, you can. If you're really like one thing after another, you're just like, two left feet, can't put it all together type thing, that's fine, start over. If you lose count when you're counting the pulse, start over. It's fine. There's no problem with that. But for the most part, you probably just need to correct one or two things. And in that case, you just tell the patient, oh my gosh, I forgot to cover you with a privacy blanket. What was I thinking? I am so sorry to expose you. Let me get this blanket on you. That way you're warm. There's no problem with that. Now, if you wanted to, you would say to the evaluator, correction, I would have put the blanket on before I pulled the sheet down. You can do that. That's okay. But who are they focusing on? Who should you be talking to? Now, you can make corrections to the evaluators. That's fine. That's allowed. But which way do you think is preferred? The patient. Yeah. Make sense? Yeah, so you can just say correction. Oh my gosh, I would have closed a privacy curtain before I started. I would have put a privacy blanket on before I pulled the sheet down. I would have had the patient check the water temperature before. I would have wrung that washcloth out, not dripped it all over the sheets. And now the sheets are wet, so I would have changed those sheets. I wouldn't leave them like that. And I would have scooted them toward me before I turned them on their side, because now they're like hanging out on the side of the bed. Oops. I would have dressed them in a clean gown so they're not laying there naked. I would have, you can correct all of that. Absolutely. That person who didn't really do much of anything corrected all those things and still passed. Now, the evaluator may suggest you might want to start again. I'd like to see some of those things, please. But understand that it's not about being perfect. It's not. It never has been. It never has been. It's about understanding that this is a person. It's real. And you're really going to go to work after this. There's a huge disconnect, guys. When you came in to take this class, you probably weren't thinking about working as a CNA. You're thinking about the test. I got to pass that test. And it doesn't help that my class is called test prep, right? I got to pass a test. So you're focused on test. But the problem is that the test is one day out of your life, and it's probably only about 4 hours out of your life if you boil it down. What are you really learning these things for? for the real world, the real people, the real processes. That's what the evaluators want to see. They're not there for the test. They're there to see how you're going to treat grandma. Because trust me, most of them are grandmas and they're getting older and they know they're going to be the body in the bed soon. And they want to make sure you've got it. That's their mindset. That's my mindset too. Because chances are I'm going to be a body in the bed here shortly. Okay.
You hold out long enough, but we take care of you.
We'll come by and visit.
Thank you. Privacy, please. But I mean, this can get real in a hurry. So we just want to make sure that we have the right focus moving forward. The test is going to take care of itself. You do need to practice them. You do. You absolutely do. Remember, you have this room available until 4 o'clock. After you graduate, from 1:30 to 4. So you have the ability to come in here and practice. If you've got a live human hanging out anywhere near your house, you should be practicing on it. Neighbors, friends, friends of neighbors, neighbors of friends. I mean, you know, pick a person. Chances are you can find somebody in your life to practice some of these skills on. But practice really is the key here. You're never going to be good at something until you've done it a time or two. Okay, good. Not bad, right? Any other questions? All right, so we have covered the test today. I just told you everything that's on the test, and we've reviewed those principles along the way. Because every single thing that I've written has something to do with one of those 5 things. Everything up there. You can read it and figure out which category it goes into. Okay. All of this is done with intention. There's a reason behind all of it. This is the state exam. 100%. Okay. So any questions on any of that? Let's get into today then. All right. Oh, that's fitting. Turn to page 57. And I couldn't have planned that if I tried. I will not be the patient for this. How do we know what to do with each patient? Care plan. So somebody, please read the care plan at the top of the page for me.
Provide the following range of motion exercise to the resident's right hip with ankle flexion / extension. Provide 3 repetitions of each exercise. The resident is not able to hold the exercise.
Okay, anybody remember what flexion extension is? What type of motion it is? Okay, all right. So bending the body part and straightening the body part. That's what flexion extension is. So if we have a patient that's laying down in bed and I'm going to flex and extend the hip, it's kind of hard to do. And the reason is because the hip is normally in an extended state. It's normally straight unless you're sitting and then it's flexed, right? But if you're laying in bed to extend the leg, to work those muscles, to maintain that muscle integrity, you have to lift the leg up. Now, this is a straight leg raise, and this is not tolerated by a lot of people because it puts a lot of pressure in the lower back, and if they have any sciatica, it's going to hurt. So we don't lift the leg while it's straight. We do not do straight leg raises. What we do is combine the hip and the knee together. And we're going to bend the knee up to the chest like they're climbing stairs and back down to the bed. And what this does is it bends the hip and the knee at the same time. So I'm going to show you on my left, not my right. So if I do a straight leg raise and my knee stays straight, it just bends this part, but it puts a lot of pressure into my lower back. If instead of doing a straight leg raise, we bend the knee up toward the chest, it bends the knee and the hip at the same time. And it's a 2-for-1 exercise, but it's also tolerated better on the back. Okay, good. So this skill, we're going to lift the leg supporting from below. We always support. We're going to bend the knee to the chest and back all the way straight on the bed. How many repetitions? 3. Then we're going to move on to the ankle. Now the ankle, we're going to bend forward and back. So we're going to bend the foot forward and back like we're stepping on a gas pedal. But if you do that with the foot laying on the bed, right? If we bend forward and back, what that does is it causes the heel to scrape against the sheet. That can actually burn the heel, can cause skin irritation, abrasions. So when we bend the foot forward, we actually want to lift that leg off the bed just a little bit. Keep the knee on the bed, but just lift that ankle up a little so that when we bend the foot forward and then back to the head, that heel is not rubbing against the sheet. Okay, so we're going to put an opening in front of it. We're going to put a closing behind it, and that's the whole skill. Man, I would want that skill. I don't want to be a patient, but I would want that skill. Somebody come lay in the bed and let me show you this one. Okay, care plan says right, so I've got to make sure that I'm on the correct side. Okay, so make sure that you're on the correct side. Hi, Ms. Jones. My name is Patty. I'm the CNA today. How are you? I am fantastic. I need to do some exercises on your right leg. Is that okay? I'm going to close your curtain. Let me go wash my hands, get my supplies. I'll be right back. I have things. Okay, this patient right here, this one, is fully clothed and lying on top of the sheet. That's how it's going to be for the test. Okay, keep that in mind. We're going to talk about something else after this skill, but I want you to pay attention. She is fully clothed and on top of the sheet. So we'll talk about something else after. All right, Ms. Jones, I'm going to do all the work. All you have to do is let me know if there's any pain or discomfort as we do this, okay? First thing I'm going to do is lift your leg up, then your knee to your chest, and then back down to the bed. We're going to do this 3 times. I'll do all the work. So I'm going to support under the knee and under the ankle. So under the knee and ankle, we'll bend the knee up. Feel okay? All the way back down. You want to make sure you're doing this slow and smooth. Up. All the way back down. One more. Up. All the way back. Feel okay? Any pain? Okay. Now I'm going to move down to the ankle. I'm going to lift your foot off the bed just a little bit. Bend your foot forward like you're stepping on the gas pedal and then back to your head. And we'll do this 3 times. So just relax for it. We're going to bend forward and back. Feel that stretch. We're going to go forward and back. Feel okay? And forward and back. Good. Any pain? Are you comfortable? Would you like a magazine before I go? Is there anything else I can get for you? The light's right here beside your hand. If you need anything, let me know. Environment is clean. Open the curtain. I have clean hands. Think about the steps of my skill. I can reread the care plan and then tell the evaluator my skill is done. Thank you. Questions? Man, I would want that skill. I would want that skill. Where's my phone? Should be trouble. All right, so this patient right here in this demonstration was fully clothed and lying on top of the sheet. That's how it's going to be for the state exam. They're going to be fully clothed and lying on top of the sheet. So no privacy blanket is necessary because they're fully clothed and lying on top of the sheet. When do we know when we have to use a privacy blanket? When the patient is uncovered or undressed. Neither one of those apply here. They're not uncovered. They're not undressed, right? Because they didn't have a sheet on to begin with. But let's say that this patient was laying in bed with the sheet up. And I've got to pull the sheet down. Do I need a privacy blanket?
Yes.
What if this patient was just laying in bed with a hospital gown on and I'm going to lift the leg up? Okay. So do you guys understand that it's not based on the skill? It's based on the patient that you're doing the skill on. Good? Questions? But luckily for you, for the test, they make it super easy. Patient's laying on top of the sheet. Easy peasy. All right. Back at the time up. Please notice that when I did that skill, I did not expect the patient to know what I was doing. I told her every step of the way, I'm going to put my hand under your knee and under your ankle. I'm going to lift your leg up, your knee up to your chest and back down to the bed. I gave them examples that they could relate to. I would never walk into a patient's room and say, okay, now I'm going to do flexion extension on your right lower extremity, because they're going to go, huh? Does that hurt? Remember, every patient thinks they're dying and they expect you to hurt them. So it's your job to make sure they know that they're not dying and you're not going to hurt them. And the only way they can know that is for you to tell them. Good? Questions? Okay, so let's move on. Talking it out is important. Let's move on to page 114, please. How do we know what to do? Care plan. This care plan at the top of page 114 tells us to provide catheter care with soap and water to a female resident with an indwelling urinary catheter. Clean the catheter tubing and perineal area only. All right, so Foley, there's different types of catheters. A Foley catheter is also called an indwelling urinary catheter. That's what we have here. And it's designed to be put in by the nurse and stay in for up to 30 days. If the patient needs a catheter long-term, it has to be changed out every 30 days. But this is the short, you know how we call chuck, disposable bed pads chucks? The short way of saying this, instead of saying indwelling urinary catheter, is Foley. Thinking the guy that made it, his last name was Foley, but I'm not sure. But there are different types of catheters. Sometimes we don't need a catheter that we're going to put in and leave in. Sometimes we just want to put a catheter in, get a urine sample, and take it out right away. It doesn't stay in. Then we would use what we call an intermittent cath. This one has a lot of names, so stay with me here. Intermittent cath, which means it doesn't stay in. Put it in when you need it, take it out. Also called a straight cath. Oh, that makes sense. And it's also called a Red Robinson because it's red. Again, I think the guy who made this, last name Robinson, but I'm not sure. So we have Foley catheters, which are indwelling urinary catheters. And then we have straight caths or intermittent caths or Red Robinson caths. So two different types of catheters, one temporary, one longer term. But what makes it longer term? Well, when a nurse puts a catheter in, this is an indwelling catheter, you'll see a little bit of material kind of bunched up here, right? Kind of lumpy. See the lumpy? When we put this in, by the way, this goes in a hole that's already there. We're not drilling. You don't get to take out that, cordless drill and zip, zip, zip. This is a hole that's already there. What we're going to do is put this tube into that hole and up through the urethra so that this part goes into the bladder. I remember at the bottom of the bladder, you've got a valve. You guys remember that? That valve is closed and it holds urine in the bladder. So our goal is to put this through a tube that's already there, up past that valve until it's into the bladder. But if we don't have anything to keep it there, it's just gonna fall out. That doesn't do anything. So putting this through the tube, past the valve and into the bladder, sure, these holes at the top would let whatever's in the bladder come out. Well, this thing does the same thing. So this has to have an additional feature that keeps it in place. So what we do is we take some sterile water and we inflate a little balloon on the end of the catheter. Whoa. Sometimes they break. Can you grab me some paper towels, please? I don't want to try to move this. It's going to make a mess. That actually happened about 15 minutes earlier than I wanted it to.
Maybe you didn't know.
No, that's okay. That's good. We're actually going to talk about busted catheters in a minute. It's just a little premature. Okay. Give me just a second. I'm going to go get another catheter to show you this. Thank you. Okay, so nurses generally put catheters in. Nurses generally take catheters out, but remember, you can be trained. This is a delegatable task. What are the two questions you have to ask yourself if you are delegated a task? Am I trained? And what? It's on the care plan, doesn't apply to this patient. Okay, those are two questions you have to ask yourself. Remember, the nurse has to ask a lot more questions to decide whether they can delegate them. Me personally, I'm not delegating catheters because if I'm still legally responsible, I don't want somebody else doing it. Me, I know what I'm going to touch with those gloves. I can't trust you guys. So let's try that again. Okay, so we have a catheter. So we get the catheter, it goes up through the tubing, through the valve at the bottom. I need water. And then we're gonna get some sterile water. Don't look. Okay, then we get some sterile water. We have this going up through the valve. Then the nurse is going to inflate the balloon. And what that does is it keeps the catheter from coming out. It sits right above that valve, and that valve actually holds that balloon inside the catheter. Now, you can't feel this. This is inside your bladder. Your bladder is a hollow organ. You can't feel this. This, inside your urethra, inside the tube, you can feel this because it's got to fit snug. If it doesn't fit snug in there, urine's going to leak around and out. And then what's the point of the catheter? Because now we got leakage. So it's got to be snug. How many of you guys have pierced ears? Have you ever put in a pair of earrings that's just a little too big and they're just like they stretch a hole a little bit and they feel uncomfortable? It doesn't really hurt, but it's uncomfortable. You can't wait to get those earrings out. It's just like it's uncomfortable, right? This is the same thing. Catheters are uncomfortable because it's a snug fit, but they shouldn't be painful. There's a difference between uncomfortable and painful. Do you guys understand the difference? I am uncomfortable, but it's not really painful. Okay, so pain we're going to talk about in a minute. Pain's something a little bit different. But because this is a snug fit, it might be a little uncomfortable. The body does get used to this. It takes about 10 to 12 hours before your body really starts to accept that, okay, this must be our new normal. I'll have to live with it. It's okay. Now, the other part of the discomfort with catheters, remember this is a hollow organ, right? But these holes are letting all the urine that's inside the catheter drain out. So that's keeping your bladder small. It's not filling with urine because it's constantly empty. Keeps the bladder small. That means that the top of this catheter is hitting the top of your bladder. Can you guys see that? Hits the top of your bladder. Now, there's only one thing ever that has hit the top of your bladder, and that's pee. So your bladder is kind of a stupid organ. It only has 2 words to communicate with the brain: pee and pain. That's it. You only have 2 types of nerve receptors: pressure, which is pee, and pain, which is pain. So when that catheter tip hits the top of your bladder, the bladder thinks, okay, it's not pain, so the only other switch I have to flip is pee. So patients with catheters often feel like they have to pee. They don't. The pee is coming out automatically. Just falls down the tube. No thought process required. You don't have to go. Okay, it just kind of goes on its own. What they're feeling is not the fact that they have to pee. It's the tip of the catheter hitting the top of the bladder. It's a sensation. Again, that will go away in 10 to 12 hours. But those 10 to 12 hours, man, you got some discomfort going on, you got this pee situation going on, and it's just not really optimal, okay? So when your patient hits call light, goes, oh my gosh, I gotta pee, it's okay. That's just the catheter. It's okay. What do we do with everything the patient tells us about? Report it to the nurse. Now, remember I said that pressure and pain are different? If we have a patient that hits call light and says, oh my God, it hurts, it hurts, it hurts, it hurts. What do we do with all observations? But this time you're gonna run. You're not just gonna walk, get to it eventually. This is not normal. Anybody ever have a Charlie horse in your leg? You know, a serious muscle spasm that's like a 12 out of a 10, seriously hurts? Well, in some people, like less than 2% of the population, some people, when we put this catheter in and we inflate that balloon, the bladder sees it as a foreign object and contracts to try to push it away. And that is called a bladder spasm, and it feels like a Charlie horse, but in your bladder. And it is painful. So the nurse needs to know about this right away. This is not a when you get to it type of thing. This is, you need to let the nurse know that they're having pain. Pain is not normal. Good, good. There's a couple things that we're going to do. The first is, as a nurse, I'm going to figure out, do they really even need that catheter? Can they pee without a catheter? If they can pee without a catheter, they don't need a catheter. That's my first question. Do we even need this thing? And if the answer is yes, then there's a medication I can give them. They can put their bladder to sleep. So no more pain. Sounds awesome. Except that some people, the side effect of this is that the bladder never wakes up. Ever. Ever. That's a problem. Because now we need a catheter forever. So this is a really serious decision that has to be made. And we need to address it head on. Okay, does that make sense? As a CNA, you never get to decide what's normal and what's not. You're going to report everything to the nurse, but if the patient's having pain, I want you to report it quickly. Okay, good. Questions? All right. To take a catheter out, this is something I'm much more likely to delegate, taking a catheter out. We simply take a syringe, put it on our port right here, withdraw the water, and it slides right out. Taking a catheter out, easy, easy.
Only pull?
Hmm?
Pull it out?
Don't even have to pull it. I mean, it just like slides out. It's like lunch spaghetti.
Why would it hurt if somebody, whenever they take it out? Why would it hurt? I mean, like really firm.
That tells me they did not deflate the balloon. Think about it.
Serious?
Well, think about it for a second. Right? We have, remember I said this fits snug, right? So this is about the same size as your urethra. This fits snug inside. Okay, this is inside the bladder. You can't feel this. It's inside the bladder. So if we don't deflate that balloon and we pull on it, that balloon is going to go through an opening that big. That's going to mean we're going to tear some of that tissue, and we'll probably get some burning, right?
I remember I have one, and they only pull it, but it was painful.
That's why I refuse it.
And then I feel the real pain for a couple hours.
Yeah, that's because they did not fully deflate the balloon.
Why would they not deflate it?
Why did our food service people touch the trash can lid? Yeah, not following procedure, not paying attention to what they're doing, or they were trained by somebody who didn't know any better.
I've had catheters before and they were painful going in and out. So I don't know what happened.
So in some people, now pain is a little bit different than
It
irritation.
wasn't the
No,
same.
Okay. So some people have very, very small urethras. Okay. If I'm trying to put a tube this big through an opening that is much smaller, right, we're going to be stretching that tissue. Now it does stretch. It does stretch, but that, yeah, that stretching is going to be painful. So to me, it sounds like when you had a catheter inserted, those of you who had one that where it hurt, they weren't using the right size catheter.
Oh, there's different sizes.
Yeah, different sizes. Yeah.
You gotta be careful. I had one time, the nurse, she went to pull it out. She snatched it and I just about pulled it. I mean, she just like that. And I came right up off the bed. I was gonna knock her out. And I was like, you know, and I was nice to her. I mean, there was no reason for it. It was just,
Probably having a good day.
don't take it out on the patient.
Well, now she was having a bad day.
Oh, yeah. It
Yeah.
seems like every time you go to the hospital or something, they want to do something. Oh, we got to put a cat in. No, not putting a cat in. I can get a cup. Give it to me and I'll go for it. Other than that, I don't need it. I'm fine.
So let's talk about that. So when are some times when we would need a catheter? Well, if the patient can pee on their own, We don't need a catheter because catheters have a lot of risks. We talked about this last week before I let you go on Wednesday. Remember that when we put a catheter in, this creates like a secret tunnel that the bacteria can climb, jump out of these holes, and now they're in the bladder without ever encountering any of your bodyguards along the way. So catheters have a huge risk. In fact, catheters kill about 2,500 people a year. Because, well, let's think about that for a second, okay? We have a bag that has urine. Urine has proteins in it that these bacteria need to procreate. So we get one bacteria in the bag. Remember, we don't need little boy bacteria, little girl bacteria to make baby bacteria. It doesn't work that way. All we need is one bacteria with the right conditions. So this bacteria gets into the bag, finds some protein particles, and munches away. And then the bacteria splits itself in two, and now we have two. They munch, split themselves in two, and now we have four. It's getting a little crowded in here. Let's stretch our legs. So they start to climb. And as they climb the bag, they keep multiplying. 8, 16, 32, 64, 128, and they keep climbing. And they get into this tubing here, this clear tubing. Now, it's warm, it's moist, but it's not quite dark yet, right? Because it's clear. That's the reason that your tubing is clear, by the way. So they climb the tubing. Not ideal circumstances, but pretty close. But as they climb, the urine's getting warmer, right? Because it's fresh from the oven. And as they climb, they keep multiplying. They keep multiplying, they keep multiplying. And then they get in here and we blocked out light. So we have fresh food, warm, dark, moist, doesn't get any better than that. And there's no white blood cells in sight. So they multiply, 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 and they jump out into the bladder. Now, when they jump out, it's not 2 or 3 bacteria, it's 2 or 3 trillion. This is an overwhelming infection that happens in the space of 30 minutes. It would be like all of Canada descending on Spring Hill, like in 30 minutes. Your body often does not have the defenses to be able to fight against something like that. This is why catheters are dangerous. Okay, we're going to talk, keep that in mind. We're going to talk about that in a second. But I want you to be aware that if the patient can go on their own, we don't need a tube to hold that valve open for the urine to come out. But let's say our patient has a urinary tract tumor that doesn't allow urine to come out. Well, then we need something to hold that tube open for the urine to come out. Or maybe the patient has a huge bed sore on their backside and they are incontinent. Well, we don't want that acid urine right up against skin that is open. So a catheter would be indicated. Let's say that you're having a baby. This is a wonderful time in your life. And you've decided you want an epidural because you don't want to feel it, which is a wonderful invention for childbirth. But we're going to numb you from the mid-abdomen down, which means you can't walk to the bathroom. You will not even know that you have legs for the next 6 hours. So if we can't get you up and walking to the bathroom, we got to have a way of getting the pee out. Now, when you push baby out, you're pushing everything out. I mean everything. It is not selective pushing. So you are going to push whatever is in your body out of your body. So that's urine, feces, anything. Well, we don't really want you peeing on baby's head. So a lot of times we will put a catheter in or try to get you to go, if you don't have an epidural, we try to get you to pee before the pushing starts, right? So that your bladder's a little more empty. Chances are you've had labor for a few hours, so you're probably not drinking a whole lot, right? So all of this adds up to when you push baby out, you're pushing less pee out. But in some cases, we'll put a catheter in while you're having baby to divert the urine. We're not so worried about the bowel movement part because that's below baby. Okay, good, makes sense. If you're having surgery, we put catheters in because we don't want you peeing on our sterile field. When we put you to sleep, we put everything to sleep, including that little valve. That little valve at the base of the bladder, it's gonna open. So when we put you to sleep, you're gonna pee. We don't want you peeing on our table. So we put a catheter in, okay? If the patient has a neurological condition, they drove a motorcycle, hit a tree head on, and now they're paralyzed. Okay, neurological condition. That can actually make that valve in the stuck closed position. If it's stuck closed, how are they gonna pee? Gotta have a catheter. If you have a progressive neuromuscular condition like MS, sometimes that can affect your ability to open and close the bladder. So if there's a reason that the urine doesn't come out or is coming out at a time we don't want it to come out, we can consider a catheter. If the patient is incontinent, the urine is coming out all by itself, we don't need a catheter for that. Unless there's a reason, like an open sore. But just incontinence, we don't use catheters for that. That's convenience for you. Doesn't help the patient. Good. Make sense? Okay. So sometimes, despite our best intentions, catheters get pulled out. Sometimes patients will do that, to do this. You know, catheters are irritating and it can be painful if it's too big. And especially your patients that maybe have dementia, they'll tug on it. You know? Tug on it. And sometimes they'll pull it out. Now don't panic, it's okay. You know, this bubble is going through something this size, so you're gonna get tissue tearing. You're probably gonna get a little bleeding. You're definitely gonna get some urine. But what do you think it's gonna feel like to the patient when they pee through that? Oh yeah, like peeing razor blades, man, it's not comfortable. But any injury is going to cause swelling. We just learned that today, didn't we? Any injury causes swelling. If we have swell, this is not an area that we need swelling because now we've got a situation where the pee may not be able to come out. So if a catheter gets pulled out, you need to let the nurse know right away because I've got about 45 minutes to make some decisions here. If I'm going to put another catheter in, I got to do it within 45 minutes. Otherwise, the swelling is going to be so bad, I'm not going to get a catheter in. Just, I mean, these are flimsy, right? There's not much to them. So I'm not going to be able to get a catheter in. So you got to let me know right away. Good. But the sad part is that patients don't pull out nearly as many catheters as CNAs do. Well, man, you guys pull out catheters all the time. Turning a patient onto their side. If a catheter is trapped between your leg and the bed, you'll pull it out when you turn the patient. Transferring out of bed and into a wheelchair. If the bag is on the other side of the bed, you're going to pull that catheter out. And probably the worst is ambulating with a gait belt. If you forget the patient is attached to a catheter bag, you'll leave the bag behind while you're walking the patient. And you will pull those catheters out. But the most common way a catheter gets pulled out is if the tubing, this tubing here, is coiled near the floor. Because as you're walking by that bed, you're not looking down, you're looking at the patient. And your feet will get all tangled up in this tubing and you will pull it out. So tubing needs to be coiled on the bed, not hanging off the bed near the floor. Bags should always be below the level of the patient's hips. Nobody wants recycled urine. That's just really high on my gross meter. This is a one-way trip, y'all. Okay. If you hold this bag up above their hips, whatever's in this tubing is going right back into that patient. And man, I have seen that walking down a hallway of the hospital, urine bag hung up on the IV pole. Oh my gosh. Do you know how gross that is?
Just put a light bag on.
Depends on the situation. I remember every question you ask me, I'm going to say it depends, right? But if we're going a short trip, maybe just to the bathroom for bowel movement and back, leg bag's not really indicated. Every time you switch a bag out, you run the risk of introducing a bacteria infection. Leg bags are ideal for longer term.
Yeah, I went back like 3 weeks and I had
Oh. Yeah, and especially if we're going to talk about that mobile patients. So we'll get to there in just a second.
So with the catheter, before you put it in, with the infection, how would you not get like infected by the hair?
Okay, great question. This is one of the reasons why nurses generally insert catheters for the most part. This requires what we call sterile technique. Now, so far, I've taught you guys clean technique, not sterile. CNAs, generally speaking, are never assigned sterile processes because it takes clean to a whole new level. So if I'm going to put a catheter in, I have to create a sterile field first. Then I have to clean the patient. Well, as I'm cleaning the patient, setting everything up, getting everything ready, my catheter is not exposed to the air. If you notice, it was actually wrapped in 2 different wrappings when I just took it out. So I'm going to open the outer wrapping, leaving the inner wrapping intact, but I can't touch it yet. I have to get everything set up, get my sterile gloves on, and then I can open the inner wrapping. And I want to do that as close to insertion as possible, so I don't have this kind of hanging out in the air. And then I'm going to quickly dip this into a lubricating jelly. Of course, it wouldn't be inflated. So let me give you the whole. I don't want this inflated while I'm talking about it. It's confusing. Okay, so I'm going to dip this into lubricating jelly and insert it. And that should take less than 10 seconds. But I have to be sterile in order to do that. So there's always a crossover. We call it the crossover point. When you move from clean to sterile, and then when you move from sterile to contaminated, there's a defined point at each of those. When you cross from clean to sterile, you cannot touch anything unclean, because the minute you touch something unclean, you then go to contaminated. So you have to move with intention here. One hand always stays sterile, one hand becomes contaminated quickly. Because in order to get this where I need to go, I've got to be able to see where I need to go, which means I've got to open her up to see where so that means this hand is now contaminated. I can't touch anything sterile. So it adds a level of complexity here that even some nurses struggle with. So we don't ask CNAs to do that usually. Great question. All right, so bags should always be lower than the hips, but they should never touch the floor. We don't want bags to touch the floor where there's contaminants. Okay, so everybody good with that? Okay, catheters can be used on males or females. Same catheter. This is not a female catheter, or there's no such thing. They're one size fits both sexes. The difference is that, remember that female urethras are only as long as our pinky, so this isn't going to go in very far. Probably about that far. Males, we have more tissue to go through. It has to go through the whole penile tissue to get into the bladder. So we're going to insert this a little further. Okay. It's the same sensation, whether it goes in that far or that far, it's the same thing. So it doesn't really hurt men anymore. And in fact, their urethras tend to be a little bit bigger, so they don't have as much discomfort. Now, after a catheter is removed, discomfort is actually pretty common because it's irritated. It's you have this tube in there, it's been stretching it out. But it's also, you know, the movement of the tube itself tends to abrade the inside of the urethra. So you do get some irritation, maybe some difficulty going after a catheter is removed. That's pretty common. This is why when a catheter is removed, a task a CNA will be given is, hey, I need you to make sure that she can pee. So you're going to go in and tell the patient, hey, if you pee, you need to let me know. And don't flush, I want to see it. Okay, so that is a common task for CNAs is, hey, let me know when she pees and make sure you visualize it, see what it looks like. Because I can't let a patient go home if they can't pee, because they'll end up in the ER in 10 hours, like screaming. I can't pee.
So now we want the inserted catheters, but when you insert them, how do they not fold up?
Yeah, they're very flexible. I mean, this is no more than a flexible straw. I mean, it's like spaghetti. Sometimes it doesn't.
How do you get it?
Well, the tunnel that we're putting it in is pretty rigid. You know, your urethra is pretty, it does stretch a little bit, but it kind of acts as your guide. Okay. So think of the best way for me to describe it. This is a horrible visualization, but have you ever gone to a bowling alley and seen kids bowl? They put those bumpers in it, right? Keeps the bowling ball in the lane, right? Yeah, well, that's kind of the same process here, right? Your urethra is like the bumpers. It just keeps the catheter going. But with men, particularly men who have an enlarged prostate, this can become very difficult because as you're inserting it, it kind of gets wrapped up in the prostate. And we have a special catheter that we can use for those particular men called a Coudet catheter. Now that's a little bit different. CNAs don't really need to know this. I'm just telling you because you asked. A Coudet catheter is still flexible down here. You want it to be able to move with the body because otherwise it's uncomfortable. But up here where we insert it, it actually has a removable stylus is the name of it. It's like a kind of like a thick wire that's in there, and it's going to have at the bottom here, it has a place to remove the wire, but it keeps this much more rigid so that we can guide it where it needs to go. And the tip is kind of bent like this so that we can kind of maneuver it around that prostate. And then when we get into place, we take the stylus out and it stays once it's inflated. But that's a kind of a specialized thing. A lot of nurses don't even put in the Coudet tips. We actually have urologists do that. There are some nurses that can be trained in it. So bags should never be on the floor. They should always be lower than the patient. The tubing should be coiled on the bed, and you should always know where the catheter bag is if you are moving that patient at all. Because remember, you're likely to pull it out. Okay. If a catheter does get pulled out, please make sure that you save the bag in the catheter. Because as a nurse, you're going to come to me, of course, you report everything, right? You're going to come to me and say, hey, the catheter came out. And I'm going to say, okay, where is it? Because I have to look at it. If the catheter comes out and it's fully intact, that's okay. That's a situation I can deal with. If the catheter comes out and a piece of it is missing, that means it's still in the patient. And that's a big deal. That's surgery, big deal. So the only way for me to know the difference is to look at the catheters. So what I'm going to do now is pass 2 catheters around. And you can see, this is pretty interesting because now we have a side-by-side comparison. You can see one of them is broken, but the hole isn't too big. The edges could be brought back together. The other is broken, but the hole is really wide. That tells me a piece of this was left behind. Why are you ringing? I have turned you off twice. So I'm going to pass this around so you can see. I'm also going to pass the Red Robinson so you can see the difference. Now, there is another type of catheter that we haven't talked about yet. And that is on page 116. So about halfway down the page on 116, you see something that looks suspiciously like a condom. This is a catheter. It is also called a condom catheter. It's called an external catheter or a Texas catheter. I do not know why, but this is used on men. It's not invasive. We don't put a tube in. This goes on the outside shaft of the penis, and it has that little port at the top, similar to what you see here, little port at the top, and that allows us to attach a drainage bag to it. And then the urine, as the man urinates, it goes right down the tubing and is collected in a bag. This is helpful if our patient can't get out of bed for any reason, but we don't want the bacteria risk of an indwelling catheter. So men have a little bit different option than women do. But these condom caths are designed to be left on for 3 days. It's very sticky on the inside, so it adheres to the penis to direct the urine away. The problem with that is because it's designed to be left on for 3 days, it's going to hold the urine right up against the tip of the penis for 3 days. Now, thank you. What do we know about adult urine? It's acidic. So that means that if we have a condom cath on a patient, it's got to be removed every 3 days, and very careful skin care is going to need to be done to try to protect that tissue. I have seen patients that the catheter was not removed, the condom cath was not removed, and they did not get good skin care. And let me tell you, it is not a pretty sight. And it is horribly painful for these patients. I mean, deep ulcers in a place that you probably do not want a deep ulcer. So condom caths need very special care that will be detailed out on your care plan. Follow it. Super important. Does that make sense? All right, now we do have a couple of different types of bags. So as you saw me do just a few minutes ago, the catheter, doesn't matter what type of catheter is, it has a port, an opening, a port that is going to attach to something. Otherwise, the urine's just going to spill out, right? How often do kidneys filter urine or filter blood, produce urine? 24 hours a day, never stops. 24 hours a day, never stops. Drip, 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 drip into the bladder. Now we're holding the valve open. So that means that urine is going to come out, drip, 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 24 hours a day. So if we got urine dripping out of this 24 hours a day, we got to have a way of collecting it. So we're going to use a bag. This is a bedside bag. It hangs on the side of the bed, holds a lot of urine, usually only emptied once a shift. When we empty it, we measure it, we write down how much came out. These two pieces connect right here. Now, when you connect them, you want to try to do it in a way that you're not touching the port or the inside, because remember, bacteria, it only takes one. And this is really close to the bladder. really close. So changing out this bag is you need a lot of attention to detail. Okay, you don't want the port open to air for a long time. You don't want the catheter tubing to encounter a lot of contact. You want to try to keep them as pristine as possible. But it does take a little bit of work to get this port into that small hole, because the port's way bigger than the hole. That's to keep it from leaking. But it takes a little bit of work. Now, CNAs can be trained to do this. You're not being trained now to do this. That means that if this becomes a part of your job, you must be trained to do this. Now, we used to wipe this off with alcohol before we put it in. That would kill any pathogens. But what we found is over time, that alcohol dries out this type of plastic and it causes micro cracks to form, which allows bacteria to breed, and it's a bad thing. So we don't wipe it off with alcohol now. We just try to work on our technique. My technique is not good today. There we go. To get that in there without touching this plastic with your fingers. But sometimes these big bags, like if I'm going to go to Walmart, I do not want to carry around a suitcase of urine with me. It's just, I don't know. Doesn't sound like a good idea. And if I'm going to the aquarium, I definitely don't want to carry a big bag of urine with me. So I would want something that's a little more discreet, something that I could maybe have under my clothing that would conceal it. Right now in our community, we have approximately 500 people walking around with catheters 24 hours a day, and you do not know it. They are in Winn-Dixie with you. They are in Walmart with you. They are shopping at Ross. There are people with indwelling catheters that are in your community that you have no idea because it's concealed under their clothing. This you cannot conceal. If you look at the top page 116, you'll see a leg bag. That leg bag is smaller and it's going to attach to the inside of the thigh or the calf with either elastic straps or Velcro straps. And when it starts to get full, the patient will just go to the bathroom, open the valve at the bottom of the leg bag, urine comes out. It's kind of a temporary holding bladder that you can wear and empty the bladder as you need to, okay? But most patients that are mobile in the community will use a leg bag because it's more discreet, but they're going to be, because they're out in the community mobile, they're going to be taking care of their own leg bags, right? We're not really involved in that too much. But when they go to bed, they may need a bedside bag that's going to hold more, and you may be tasked with changing the bags. Good. Questions? Let's go ahead and take your break. And when you get back, I'm going to show you 2 videos. We're going to read the care plans again, and then I'm going to show you 2 videos, one right after the other, and the rest of the class will be practice. This is the catheter in the bag. I'm going to leave it here with the syringe. You guys can play with it if you want to.
Have you ever in your care heard of a pregnant woman, like, so when I was pregnant with both of my kids at like 9 weeks, my bladder stopped working.
Oh, you have a neurogenic bladder.
And they said that my like urethra was so red and inflamed that none of the urine was able to pass. And it happened at the same point in my pregnancy with both kids. Have you ever heard of that? They said it's like really rare.
Yeah, I have heard of that. But there's a couple of different causes, actually.
I had a terrible neurologist, so
Oh,
I don't really know why.
yeah, it could. Okay, so there's, and I don't know your specific cause. I'm
I had just never heard of it.
Yeah. So one can be pressure related, okay, because baby growing, baby is literally laying on top of the bladder. So that pancakes down the bladder. And this is why a lot a lot of pregnant women have to go to the bathroom a lot because baby's weight is pressing down. So what happens, so think mechanics here, right? So what happens as you have baby growing in here, and if your bladder tip forward or backward, this can affect this, okay? But what happens is baby's weight pressing down can cause, it can cause bacterial inflammation in that area, just because you're not able to completely empty your bladder every time you go. Okay, so there's always a little bit residual in there.
It was like, what do you call it, like triggering.
Yeah.
It got to the point where I looked like I was 8 months pregnant. I was 15 weeks.
Oh my
And I went
gosh.
to the ER and they're like, so you almost died, your baby almost died because you have 3 liters of urine in your body.
Okay, so that sounds to me like it's more of a neurological issue where that valve at the bottom of your bladder is not being triggered to open completely.
For some reason when I'm pregnant.
Yeah, now this can be hormonal because our hormones are all out of whack. It could also be mechanical because of where the bladder is in relation to baby, that the mechanisms that just open that valve may not have been able to be working. It could be bacterial because your immune system was not keeping the bacterial load down because of pregnancy. It could be a lot of different things. I would probably, for me, probably lean more toward neurological hormone.
Yeah, it's somewhere that I had the exact same point with both my kids. Like,
Yeah. Have you ever had any other issues outside of pregnancy?
I've had UTIs in the past, but nothing that was like diagnosed as like a chronic condition.
Okay.
Yeah.
You may also suffer from something called interstitial cystitis as well. And that can be made worse during pregnancy. Those pregnancy hormones are excreted in your urine, and that is in your bladder, and that can have an impact as well. Hormonal. Pregnancy changes every part of your body, and we don't really think about it or realize it, but yeah, it does. It does. Not knowing your specific history or anything, those are the areas that I would think to look first. Could be something even that I'm not aware of, something
Yeah,
way
and
even
the
rarer.
ER was puzzled by it.
Yeah.
He said it's so rare that, you know, all they could tell was that the urethra was red and swollen and it wasn't letting the
Urine
pass.
out. Yeah. So I would default to either neurological or neuroendocrine. Yeah. Interesting.
That was not
No. And how many more are you having?
fun.
Yeah.
I'm 7 here, I'm 8, so
Oh.
I'm good.
You're done.
Yeah, so I'm 35, so I'm past that.
Yeah. Yep. All right. Let me go take a quick break.
No idea.
Maybe she had to work. Did you ever figure out your testing, email,
Yeah, they're just, reviewing it.
reviewing the background?
Yeah, it's gonna take up to 30 days.
What about your timeline? for moving?
I'm just gonna wait. I'm gonna have to wait.
Wait till move.
Yep. Now he says we're not gonna move until August. I'm like, oh my God. I'm gonna die before the.
So it takes up to a month for them to check the background check. So,
30 days.
yeah, because I go to get my fingerprinting and all that today, but and then she said you could what apply for the test 24 hours, I think, later. But
I don't see any point to review. I don't know if you pages later.
It says show status, is that what you
Yeah, show status.
click on that one, show status?
I tried, but
It won't click on it?
no.
Huh. Yeah, I get the same thing. I
Maybe I
get,
have to read.
Ask Patty what you do. with that.
Yeah, because I had,
Does it say under review?
mine says under review.
before say on the review, but now it's,
No, it doesn't say.
Yeah, they're still checking, because they have to go for everybody.
because first, yeah, first I get two things right here, then I fix it because it wasn't great,
Mhm.
and then it told me like that.
But they'll send you another email. Right? when they
Yeah.
schedule the test.
Yeah, they'll send you an email when they schedule the test.
Oh, okay.
I guess it's just waiting.
Yeah, it's just gonna be like,
And then I just.
yeah, I gotta go to the grocery store. I need to put three. Thank God.
I thought you had to wear gray.
And then I.
You can wear gray, green, or pink.
Those are great colors.
Gray, green, or pink.
Oh.
Pink I will not wear. I do not look good in pink. I can wear all black with a little bit of pink on it, or on a shirt, but I can't wear all pink. No. Mm-mm.
Not a pink kind of girl.
No, it looks horrible on me.
I would think with your blonde hair, it would look good. No?
Mm-mm. My fiance's like, oh, hell no. He used to go to Harley Davidson shop and try to get me a shirt. He's like, I think I like the pink one there's, but then I took a picture and I held it up to you and he goes, oh, hell, I said, I tried to tell you, hell no, it's the pink. I never wear the color pink, never. I do not look good in pink. Mm-mm. He's like, no, that's why I got you the gray one. And he sent it to me. And now I like it. Now I can't. He's like, so I wore it the other day. Every time I saw because I Harley Davidson it said Screaming Eagle on the back. And I had the gray scrubs on. So I just kind of like left it, except not the three button, I left that one. And nobody said anything to me. Got away with it. I'm worried about people. Big bosses are gone. It's like a vacation for us on the weekend. All the big bosses are gone.
They don't want to work.
No. And nothing, just said, that's a good thing. We don't get bothered.
Okay, so let's go back to page 114. Last two skills that we're learning is catheter care and emptying the drainage bag. They're two separate skills for the test, but in most places they're going to go together. Catheter care is generally performed once a shift. Emptying the drainage bag is performed once a shift. So in most places, you're going to do them at the same time. Okay, make sense? For the test though, they count as two separate skills. So you would do your opening skill, closing, opening skill, closing. So on page 114, our catheter care plan tells us to provide catheter care with soap and water to a female resident with an indwelling urinary catheter. Clean the catheter tubing and perineal area only. So you guys remember pericare? This is pericare, the front part of pericare, and we're going to clean the tubing. It doesn't tell us to clean the backside. It says front part of pericare, pericare and tubing only. Okay, so we don't have to clean the backside, and that's because there is a tube there collecting urine. Their butt's not laying in urine, so it doesn't need to be cleaned like it did for pericare. Good. Okay, so we're going to do the opening, catheter care, the closing. You're going, all the same standard rules apply. So we follow the care plan. We're going to use a barrier. We're going to wear gloves. We're going to cover the patient with a privacy blanket. We're going to clean rolls toward me, dirty rolls away to put the pad under them. You're going to scoot them towards you and roll them on their side when you're turning them. Washing rules apply. We get water, we check it, they check it. Whatever you wash, you rinse. Whatever you rinse, you dry. Don't get the surface wet. All of these things that we know are going to apply to that. So there's nothing really new in this skill. You already know how to do pericare. We're going to use leaves, one down the middle, one side, the other side, skin fold, and you're going to clean the catheter tubing. It doesn't matter which one you do first. You want to do the tubing first, that's fine. If you want to do pericare first, that's fine. Nobody cares. But when you're cleaning the tubing, remember it's being held in place by that balloon, right? So we don't want to grab the tubing and pull on it when we're cleaning it. We want to hold it in place with one hand while we clean the tubing, moving away from the urethra. Remember, that's one of our principles. We always move away from the urethra. So we're going to put the washcloth around, wipe away, fold that leaf over. We're going to do it again, fold that leaf over. Do it again, fold that leaf over, do it again. So 4 times we're going to clean that tubing. Whatever we wash, we rinse. Whatever we rinse, we dry. So nothing new there. You're going to clean the basin, same way we clean all basins. It's only holding water. No dirty washcloths go back in that basin. And then we're going to do our closing, same way we do closing. There's nothing new here to learn, really. But we are going to learn something new on drainage bags. Go to page 117. And this tells us to empty the resident's urinary drainage bag into a graduate container. We need to measure it and then document on an intake and output form. So we have to talk a little bit about the graduate container, because this is new to us. This is a urinary graduate container. It's often called a triangular graduate for obvious reasons. Looks like a triangle. It's going to have markings on the outside. This cup has markings in ounces and cc's. Which one do we use in medicine? So we're only going to pay attention to this side. There's something very specific when you're measuring anything in medicine. There's 3 rules we have to follow. It must be measured on a barrier. So anything that has a body fluid in it, I can't just set it on a surface. It's got body fluids. So it's got to be measured on a barrier. It also has to be measured on a flat surface. I can't hold it because it can spill. And it has to be measured at eye level. So for this skill, I'm gonna have this cup on a barrier on a flat surface, and I actually have to get down and measure it at eye level. Okay? Now, for those of you who have any problems, this might be a bit challenging, but you still have to do it. Good. Now we're gonna round to the nearest line. So if you look here, I'm gonna pass this around. If you look here, you can see that these are marked in 50. So you can see the line here for 200, the line for 250, the line for 300, 350, 400, and so on. There's little tiny lines in between. Those are 25s. So if this is the line for 200, the little line above it is 225, then 250, then 275, then 300. In medicine, we round to the nearest line. Doesn't matter whether it's up or down. Nobody cares. Just nearest line. But you can't measure 212 cc's in this. It's not that specific. So all of your documentation needs to be in, 25, cc increments. Like you can have 200 or you can have 225, but you can't measure 212. Does that make sense? Okay, when we're emptying the bag into this container, it's got to be on a barrier. So we're going to put chunks on the floor, get the cup, and then we're going to empty the urine into the cup while it sits on the barrier. But while we're emptying it, we don't want that port to touch anything, because any bacteria that gets on that port gets in the bag, climbs the bag, and gets into the patient. So that port can't touch your hand. It can't touch the bed. It can't touch the bag. It can't touch the cup. Nothing. That port must remain pristine. That makes sense? That is one of the really, really, really big check points in this particular skill.
You would need a clean set of gloves and you would only touch like the top of the port.
Right. So I'm going to show you here. So when we're going to get our gloves on, get the cup, don't touch that cup without gloves. I know I just passed it around, but it's clean. But in a clinical setting, this only gets rinsed out, dried off, and put away. So you don't want to touch this cup without gloves. So you're going to put a barrier on the floor. You're going to get your gloves on, put the cup on the barrier. And then when you're going to empty this, you remove it from its house. And I cannot touch that port. So this is a slide valve, what we call a T valve. So you simply slide it to the side. So now it's open. You guys can see through it now. It's open. So when I open it, I'm going to position it over the cup, kind of pull a little bit to straighten the bag, empty it. But notice I'm not letting that port touch anything. Once the bag is empty, I'm going to close that port and then put it back in its house. But when I'm putting it back in its house, I can't touch anything with it. So I'm just going to put it right back in. Not.
You normally wipe it off because we wiped it off with the alcohol swab.
No, remember I talked just a little while ago about how we found that the alcohol dried out that plastic and caused little micro cracks to form. So that used to be the accepted process, right? Everybody was taught to wipe the port with alcohol before you put it back. But they've actually found that that's counterproductive now because it dries that port out and causes cracks to form and bacteria hide in cracks.
I have to read what we use then because we have the crackers and something and we have to wipe it down before we put it back.
Yeah, you'll want to go to your policy and procedure manual because again, you were probably trained by somebody, right? And that somebody may be using an old procedure, not realizing that it's changed.
Okay.
So anytime that there's a discrepancy, you should always go to your policy and procedure manual, because the person that trained you may not even know that we don't do that anymore.
Patty, I think you need to be a nurse. You know this stuff inside and out.
It's just experience.
Still.
So that's no longer, we used to, if you look at my old videos from 2012 on my website or on YouTube, it's on YouTube, you'll actually see my old videos. I cleaned the port with alcohol. That process changed in early 2016 was when we changed it. So the new video does not have using the alcohol back. Okay. Good. Questions? Okay, so this is going to go on a barrier when we're emptying the bag. We don't let the port touch anything. We put the port back in its house without touching a lot of stuff. But can I carry an open container of urine through a room?
No.
So that barrier is actually going to be wrapped around this cup for transport. So I'm just going to take that barrier, wrap the cup up in the barrier and take it over to the bathroom, but that gives me my barrier to measure this on. Remember I said I need 3 things to measure: on a barrier, on a flat surface, at eye level. So that barrier is going to do double duty. It's going to be a barrier here and there. Okay, good. And then I'm going to put it on the lid of the toilet. I'm going to get down on my knees, maybe, and measure it round to the nearest line. And then we're going to dispose of the urine. Where does urine normally go? Yeah, the toilet, absolutely. Do not put this in the sink, please. This is gross. So we're going to dump it in the toilet. Then we're going to rinse the cup out. Where should the rinse water go? In the toilet as well. Then we're going to dry it and put it away. Remember, this is not sterilized. Don't touch it without gloves. Do as I say, not as I do. I know, sitting here holding it without gloves. Okay. Toileting items go in the bottom drawer of the 3-drawer cabinet always. The bottom drawer. So this 3-drawer cabinet here, think of it like a body, right? All grooming stuff goes in the top. All bathing stuff goes in the middle. All toileting stuff goes in the bottom.
That's how it's gonna be in every facility.
That's how it's going to be for the test for sure. And if your facility is not set up like that, I would probably make it so, because you never want toileting stuff above toothbrushes. It's just a thing. Just a thing, you know. So yeah, if it's not set up that way, I would set it up that way, because somebody along the line is not thinking. You don't want anything on top of room.
I'll have to do some burns on that.
So good? Did I get you fast? All right, let me show you these 2 videos. I'm going to show you the videos back to back. Remember that for the test, they're 2 separate skills. Okay, 2 separate skills. I'm going to show you the videos, one right up the other, but they are 2 separate skills. Thank you. All right. And then the rest of your class is going to be practice. I have a few more things to tell you. But congratulations. You made it. Was the class as hard as you thought it was going to be?
No.
I thought was more harder for me, but no.
Good.
I'm very confident.
Good. My whole goal, just like your badge says, we make CNA training easy. My whole goal is to make this so easy that you would never think of any other way to do stuff. It's just like, well, of course you would do it that way. Why wouldn't you do it that way? Doesn't make any sense to do it any other way. That's my goal.
Is there an easy way to remember like what supplies you need for each?
Yeah, that's.
Oh, that's a very good question.
Reading about that for the
Yeah.
test.
Okay, so yes, there is an easy trick.
I would love to.
If you're washing a small body part, hand care or foot care, right? Do you remember when we did hand care, how many hands we're washing?
One.
We're washing one hand. We have to wash and rinse. So I need 2 washcloths, right? So small body part is 2. For washing anything else for the test, it's 4.
like,
So
hand
washcloths,
Two.
Yep,
foot
hand-
is two.
hand care, foot care 2, small body part 2. Everything else is 4. Now for towels, you need 1 for everything except bed bath. Because we have to protect the bed. Okay, so for washing, and remember, most of what we do is washing skills. So we have hand care, foot care, partial bed bath, peri care, catheter care. It's a lot of washing skills. So the easy way to remember is small body part 2, washcloths, everything else 4 washcloths. Everything takes 1 towel except for partial bed bath. Longest skill gets 2. That's how I remember. Longest skill gets 2. Bed bath. Now, the rest of the supplies, well, you just kind of have to make it make sense to you. So if you're brushing teeth, what do you need to brush teeth?
There's your base toothbrush, a couple of water.
Yeah, so you just kind of have to think, what do I use to brush teeth? Well, I have to have a toothbrush. I have to have some toothpaste. I gotta have some water. I gotta have towel to wipe off my face after I'm done. I'm need a somewhere to put it all. So let me get a barrier. And I probably need gloves because I'm doing this on somebody else. Brushing my own teeth, no gloves. Somebody else, yes, gloves. And I'm going to make a mess because I'm on somebody else. So let's get a clothing protector. So you kind of have to make it make sense to you. Now, yeah, you can't just memorize a list, but you're not going to have as good recall as if it makes sense. So what about changing somebody's clothes, dressing somebody? Our care plan says that we're putting a long sleeve button or snap front shirt, pants, and socks. So care plan tells me those 3. Anytime I'm uncovered or undressed, I need a privacy blanket. And gloves, you can if they have a skin opening. You don't have to wear them for the test. Yeah, and then everything that we get supplies for requires a barrier. So there's my supplies for dressing. Range of motion. Do I need supplies for that? No, those are easy. Pulse, respirations. No, I just need I need my documentation form and a pen. That's it, which they're going to give me before I start my skill. Awesome. So I don't have to go get anything.
The gown,
Gown,
it's only for shower and wear the teeth.
bed bath, that's it. That's the only time we're going to change a gown is bed bath. That's it. We take the gown off to dress them, but that just makes sense. Oh, let's go to the hard one. What about bedpan? How many times have I turned my phone off today? Oh my gosh, I keep turning it off and it keeps coming back on. I swear this thing is possessed. Let's talk about bedpan. Can you flip the lights on while we're talking, please? We'll get to these skills in a minute. Let's talk about bedpan. So don't look at your book. Don't think about this too much. Okay, so we definitely need a bedpan for bedpan, right? Need a bedpan. So our care plan tells us patient can wipe themselves, so we're gonna have to give them toilet paper. Okay, so they wipe themselves, we need wipes for their hands. We have to provide privacy, so let's get a privacy blanket, right? And yep, because that bedpan's going to go up and down, we need something on the bed to protect it. And we probably need some gloves for this because ooey gooey for sure. So we can kind of reason out our supplies. Do you know the best time to do this? When you start your skill. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm here to help you with a bedpan. Is that okay? I'm going to close the curtain and go wash my hands. You are at the sink for how long? Minimum. And that's not even counting your nails. So you're actually probably over at that sink for like close to a minute. That is awesome thinking time. When you're standing at that sink washing your hands, you should be thinking about what supplies do I need for this skill. And if you wash your hands often enough, it becomes routine. You don't have to think about it. You're not looking at the clock to measure your time. You've got this down, right? So it's a really good idea to think about your supplies while you're washing your hands, getting ready for the skill. Now, the next question is, well, wait a minute, I only have to wash my hands for the first skill. What about the other two? You can go to that sink and wash your hands anytime you want to. They aren't going to they're going to tell you can simulate. They're not going to tell you you have to simulate. So if you need to buy yourself a little bit of time, if you need to stop and think, you're allowed to just stop and think. You don't have to go to the sink. You can just stand there. That's perfectly okay. You can do that. Or you can go to the sink and wash your hands if you want to at least look like you're doing something. That's okay too.
Can I check the care plan one more time?
You can read the care plan anytime you want to, but I want there's a caveat to that. Okay. Remember, the care plan is only going to tell you this.
Yes.
The care plan does not tell you your supplies. So, I mean, some care plans will tell you some of your supplies, but remember your supply list, which is on the page, that's not on. Okay. But yes, you can read that care plan anytime you want to, but make it make sense. Don't get so caught up in, I need this and this and this and that, and try to do this whole list, and it gets really confusing for you. Make it make sense. Remember, these are all skills you do on yourself. I mean, except for catheter care. Of course, you don't do that on yourself, and it's a washing skill, right? But you guys wash yourselves, don't you? I hope so. You guys feed yourselves, don't you?
Yes.
You guys brush your own teeth.
Yes.
You get dressed.
I feel like the supplies are different.
Well, here's the thing about supplies, okay? And this supplies are, everybody gets tripped over. You're right on track. But if you look at this, these are your checklists. This is actually what they're grading you on, right? These are the actual real testing checklists. The actual ones. There, if you go through and you read these, there are no steps on here, none, that say got appropriate supplies.
So they're not grading on supplies?
They're not. There's nothing here that says got the right supplies. They're grading you on what you do with those supplies. So again, this goes right back to the patient. Doesn't have anything to do with you.
So if you
Right.
forgot
So
something-
if there was a checkpoint that said got appropriate supplies, that means that their focus is on, yeah, and who is it supposed to be on? That's why that checkpoint isn't there. So they're not grading you on supplies, they're grading you on what you do with the supplies. So let's say that you are, let's say you're doing catheter care. Okay, we haven't seen the video yet, I know, so just bear with me. Let's say you're doing catheter care. And you go over to the supply shelf and you get your barrier, because we always start with a barrier. Do you see how I'm using repetition here, guys? I'm saying the same thing the same way about 100 times. When you get into the test, do you know what you're going to hear?
Your voice.
The same thing the same way. But they're short, and they're short on purpose. Because when you look at that patient over there and you see they're uncovered, your brain is automatically going to trip. They're uncovered. You need a privacy blanket. You're not going to be able to help it. You are going to be incapable of stopping your brain from saying those sayings. Okay. I do this on purpose. So you go get a barrier, because we always start with a barrier. And you're at the supply shelf and you're like drawing a total blank. Oh my gosh, I have no idea what I need. This is catheter care. I don't remember that. I am lost. It's a washing skill. So what do I need for a washing skill? What do I need? What do I need? What's a big body part? So I need some washcloths. Small body parts are 2. Everything else is. So I'm going to grab 4 washcloths. Whatever I wash, I rinse. Whatever I rinse, so I need a. So I'll grab one of those. I don't know if I have to change the gown for this. I don't know. Let me grab one of those just in case. And it's a washing. I got to have something to hold some water. So what do I need for that? Basin and soap, because my care plan says soap and water. Okay, I got that. I don't know if I need lotion. I put lotion in this area. Did we put lotion here? No, I'll just leave lotion. That's fine. All right. Gloves, personal skin. Well, I need some gloves. All right, I'll get some of those. Okay, I'm good. I'm good. Got all my stuff here. And get my water. I check it. Who else checks it? Patient checks it. I'm all set up. I'm getting a towel over their legs. I roll the gown up and now they're exposed. What did I forget? Privacy blanket. Now I did that on purpose, okay, because I'm leading you there. So I'm now in front of the patient with my gloves on. I've got her exposed. I don't have a privacy blanket. And my brain is going to tell me, hello, there is no privacy blanket here. So now, remember, there's no checklist. That checklist does not say got appropriate supplies. What it is going to say is made sure the patient's privacy was protected and minimized exposure throughout the process. Now, I don't have a privacy blanket, so I'm not getting a check mark there. I realize I don't have a privacy blanket, so what could I do? I could. Can I reach in there with gloves on them? Okay. But let's backtrack a second. Yes, I could make a correction. I could. But I want to backtrack a second. I got washcloths and whatever I wash, I rinse, whatever I rinse, so I have a towel. Is it possible that I could put a towel over her to protect her privacy? So even though I don't have a privacy blanket, remember, the care plan doesn't say got privacy blanket. It just says protect the patient's privacy and minimize exposure. Could I do the same thing with that towel that I have there?
Yes.
So this test is designed to be flexible. Okay. Does that kind of help you guys a little bit?
Yeah.
So if you didn't want to take your gloves off and go back over there, you could say to the patient, I'm going to cover you up with this towel and minimize your exposure. I'm only going to expose what I need to.
You made me more relaxed because I try to memorize everything.
Okay, now I am going to tell you where we're going to run into a problem here, though, because this is going to take a little problem solving on your part. Okay, the reason that we use a privacy blanket, now we could use a towel, but that creates a problem a little bit later in our skill. The reason that we use the blanket is because of that one small thing I just said, minimize exposure, right? So that means I need to expose as little of the patient for a short amount of time as possible. Now, I can't touch that sheet that's going to go right up next to her face with soiled gloves. Everybody remember that? Mm-hmm. So if I take that towel away, my patient is uncovered and undressed, and I can't touch that sheet. So this causes a bit of a problem in our flow. So what we would have to do is leave the towel on the patient until we're all done with everything. We cleaned everything up, we put it all, that towel would have to be our privacy blanket. And then we have to remove our gloves to take the towel away and pull the sheet up. So it's going to mess with your workflow a little bit. But you have to remember all the principles you were taught to work that out. Everything that you need to know is up there. Every single thing that you need to know throughout your entire career is on that wall. Every one of them. You'll learn how to adapt them to different situations as you go. So here's something funny about hand washing. A couple of years ago, I was in, I think it was Walmart. Pretty sure it was Walmart. Could have been Sam's. I'm not sure. But anyway, I wasn't paying a bit of attention to anybody around me. I'd gone to the bathroom. I'm standing at the sink and I'm washing my hands. And I'm not thinking, I'm just washing my hands. And I hear somebody behind me start to laugh. And she says, "Oh my God, you really do wash your hands the same way every time, don't you?" And I turn around and been a student that I've had like 8 years ago. But yeah, I mean, if you see me like at Sam's in the back, I am still washing my hands for 20 seconds. I mean, it's the same process. Tops of the wrist, backs of the hands, in between the fingers, in between my thumb and index finger, bottom of my hand by my pinky, palm of the hand, rub, 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 and then I rinse and then I dry. It's the same process. It doesn't matter where I am. I'm cooking in my kitchen. I'm doing the same hand washing because it doesn't make any sense to not do it that way, because that is the way that kills pathogens. Why are you washing your hands? To kill pathogens. If you're not doing it the right way, you might as well not do it at all. So yes, I wash my hands the same way, whether I'm in this classroom showing you, or I'm at Walmart, or I'm in my kitchen making a chicken dinner. I'm washing my hands the same way. So I can now wash my hands without being aware of what I'm doing, because I do it the same way every time, never vary from it. Now, if you start that process, when you get to the test, you will not have to think about your hand washing. Does that make sense? Just a thing to think about.
No, I already did it after you showed us. I started doing it, so it'd be a habit. Now Holman's like, "What are you doing with your hands? Just wash them." I said, "I know."
Yeah.
He's like, "You're taking too long." I said, "No, I ain't. I still got, oh, okay, now it's 20.
Yep. Yeah.
Well, she said, "You do it this way and it kills pathogens."
Yeah. Well, here's the thing. I see people in public restrooms all the time that just, put their hands under the water and walk out. And I'm like,
They're like the nothing. That's
Yeah.
nasty.
yeah, your hands are warm. Now they're moist. Pathogen's still there. Yeah, absolutely. Yeah. Now, the only thing you got going for you is the fact that they're visible at this point. And you're going to pick up that hamburger? Really?
That's nasty. But you think
Really?
about it. Ugh.
Yeah.
And yet it happens all the time. But, those are still better than people that just walk out of the bathroom and totally ignore this thing. But still, it's amazing. Once you become aware of this, I'm hoping to change some of your habits just to give you guys a healthier life as well. So supplies really should not be too much of a sticking point on you. Remember, it's not about you, it's about the patient. So what we have to think about is, how does that particular supply affect the patient? If we forget that supply, that impact on the patient is what they're going to be grading us on.
Can you gather, like if you forget something, can you go back and gather it?
Absolutely. Anytime you want to, but you cannot reach into any clean areas, whether it's a 3-drawer unit or the supply shelf, if your hands are contaminated. Remember that crossover point. You're going to get to a point, you had clean hands, you washed them, you got your clean supplies, but the minute you touch that patient or put on gloves, you are now no longer.
You have to wash your hands and then go get the supply.
Yes. Yeah. And then reglove. Okay. Great question. Good question. Any others before I show you this video? These videos. Okay.
Jones, my name is Patty. I'm your CNA today. How are you? Good. I need you to catheter here. Is that okay? I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. Okay, Ms. Jones, I'm going to gather my supplies. I'll start out with a barrier that provides a clean place to put my supplies. And we're going to get 4 washcloths, a towel, a chucks, a privacy blanket, and now I'll have my basin and soap. And a soap box. I'll just get some water. I'll be right back. Okay, would you like to check the water temperature, make sure it's okay? It's good? Good. I'll place the washcloths in there to stay warm. And I'm gonna cover you with a privacy blanket. This is gonna help protect your privacy and keep you warm while we do this skill. And I'm gonna pull your sheet down to about your knees. Okay, Ms. Jones, I'm gonna place this pad underneath you. This is gonna help keep your bed dry while we do this skill. First, I'll roll it toward me. And place it on the bed. And then I'll put my gloves on. All right, Ms. Jones, can you scoot toward me, please? Thank you. And can you roll onto your left side? 1, 2, 3. Thank you. Going to be very careful, making sure that the catheter tubing rolls with the patient and doesn't get pulled on. I'm going to unroll the chucks underneath the patient's hip and have the patient come back onto their back, making sure that they don't lay on that catheter tubing. Ms. Jones, can you scoot to the middle of the bed, please? Thank you. Ms. Jones, can you scoot toward me? Thank you. And roll it onto your right side. 1, 2, 3. And now I'm going to unroll the chucks to protect that. Come on back, Ms. Jones. And scoot to the middle of the bed. Thank you very much. Okay, now I'm going to start cleaning the catheter. I'm going to roll your gown up inside the blanket. I will be exposing you, but we'll make this as brief as possible. Please let me know if you're uncomfortable. As I roll the gown in the blanket, I want to make sure that I don't grab the catheter, that we don't cause any unnecessary pulling or stress on that catheter. And now we'll cover her thighs with a towel. This exposes only the area that we're working on. I'm going to take a first washcloth and wring it out. And apply soap to 4 leaves. 1, 2, 3, 4. Now I'm going to clean your catheter. I'm going to hold the catheter where it exits the body, wrap the washcloth around, and wipe away from the body. Fold that leaf over. I'm going to hold it, wrap the washcloth around, and wipe away from the body. That's 2. We're going to do this 2 more times. Away from the body. 3. And the last one. 4. I'll set this washcloth aside. Whenever we wash, we must rinse. So I'll bring this washcloth out, and we'll use it to rinse that catheter the same way we wash. I'm going to hold it where it exits the body, wrap the washcloth around, and wipe away from the body. We'll do this 4 times. 2, 3, and 4. Set this aside. Now we'll dry the catheter. Now we're going to do pericure. We'll take a washcloth out of the basin, bring it out really well. And we're going to soak 5 corners. 1, 2, 3, 4, and the back side is 5. Okay, now I'm going to clean the peri area. I'm going to lift the catheter up out of the way with my feet and hold the labia open while I clean down the center of the first lead, always going top to bottom. And then we'll remove the washcloth and fold that lead over. Now I'm going to clean down one side of the labia, top to bottom, fold that lead over. Clean down the other side of the labia, top to bottom, fold that lead over. I'm going to clean the skin fold between the groin and the leg, fold that lead over, and clean the other skin fold between the groin and the leg, and then set that washcloth aside. I'm going to take the final washcloth and wring it out really well, and we're going to rinse all of those areas the same way that we washed them. So I'll pull that catheter out of the way and spread the labia open, laying down the center, top to bottom. Fold that leaf over, clean down one side of the labia, fold that leaf over, rinse down the other side of the labia, fold that leaf over. We're going to rinse the skin fold, fold that leaf over, and the other skin fold. Set that aside. Now we'll dry gently by patting dry top to bottom, and then removing the towel. Ms. Jones, I'm going to cover you back up. I'll unroll that blanket, which will replace the gown over the patient. I'm going to make sure that the catheter and the tubing is coiled on the bed, not near the floor, and not where the patient is laying on it, making sure it's not kinked. Ms. Jones, I'll be right back. I need to dispose of your supplies. The towels and washcloth will be placed in dirty linen. The basin is going to be cleaned the way we clean everything else. We'll return the basin to the drawer, and on the way we'll pick up the soap. We'll open the drawer with the paper towel and return the basin to the storage area. Now I'll dispose of my paper towels. Okay, Ms. Jones, I need to remove the chucks from under you. Can I get you to scoot toward me, please? Thank you. And can I get you to roll them on your left side? 1, 2, 3. Thank you. I'll roll this soiled chucks toward the patient and tuck it under her hip. Come on back, Ms. Jones. And scoot back to the middle, making sure the patient is not laying on that catheter tubing. Okay, Ms. Jones, can you scoot toward me again, please? Thank you. And roll up on your right side. And I'm going to remove that chucks from the back. Okay, you can scoot back to the middle. Thank you. This is going to be thrown away. Okay, Ms. Jones, let me just look at your catheter one last time. Make sure that the catheter tubing is coiled on the bed, that the catheter is not on the floor. Everything looks good. I'm going to remove the chucks from the table, and we're going to throw this away. And then I'll remove my gloves. We'll throw those away. Okay, Ms. Jones, I'll pull your sheet up now. And I'll remove the blanket as I do so, rolling it into a ball. You put this in dirty linen. Okay, Ms. Jones, here's your call line. If you should need anything, just let me know. Are you comfortable? Can I get you anything while I'm here, like a magazine? I'm just going to open your curtain and wash my hands. After washing my hands, I'll think about the steps of my skill, make any corrections that need to be made, and then tell the evaluator my skill is done.
If you were doing catheter care or pericare on a,
Now,
or anybody on a patient and they weren't able to scoot and move to the middle, would you need someone else helping you with them?
so the answer to that is, it depends. Do we have a draw sheet on the bed? If we have a draw sheet, we use that as a sling to move the patient's body weight toward us so we can turn them on their side. Do they have an order for two-person assist? Do they have very fragile skin where sliding them is not a good idea? And we would have to use some sort of mechanical lift to keep them from sliding. Yeah. Yeah. It really depends on the situation of the patient. If we've got somebody with severe osteoporosis and she's got compression fractures all up and down her spine, then I don't want you sliding her anywhere because that can cause bones to break. So every situation is going to have to be handled just a little bit differently based on the needs of that particular patient. That's where your care plan is going to come in. Good question. Very good. Male pericare is covered in your catheter care skill. It's at the bottom of the page toward the, and I think it goes into the next page as well. But it talks about how to do male pericare.
114.
Should be like 111. Yeah.
Oh, I see.
So if the male has a catheter, we're going to use that male pericare procedure, clean the catheter tubing the same way, but we'll use the male pericare procedure.
We'll do circular motion.
Yeah, you start at the tip of the penis and then always work away from the urethra. So we start at the top and we go down the shaft away from the urethra.
Okay.
Do you go away from the body?
Yeah. Okay.
Oh, so
You don't
would
wanna
you
go
would
off.
yeah, you're going to start at the top of the penis and you're going to go down away from the urethra.
Away from that opening.
Right, right. By the way, don't sightsee. This shouldn't take very long, like 15 seconds. I mean, guys, it doesn't take a genius to figure this out. You got warmth, you got wet, you got a human hand. Let's get this done quickly. You will get a reaction if you're there too long.
Yeah, we don't move that.
So, yeah, move along. Hey, it's physiological, you know, I mean, it's nature. It's nature. Is it venture care? That is not where we're supposed to be.
Hi, Mr. Jones. My name is
Oh,
Kathy.
yeah, we don't want to hear him. No, no.
Wonderful.
I'm sorry, hold on one second here. Thanks,
You know, he's excited. We'll be recorded.
Oh, yeah. The, there we go. I told him the other day that we are, there it is. Told him that we're getting ready to retape the videos and he's like, he's a good kid though. He'll do what Mom tells him to.
You the one that got that really bad injury that you have to.
Yeah, it's, he's.
Ms. Jones, my name is Patty. I'm your CNA today. How are you? Great. I need to empty your urinary drainage bag. Is that okay? Okay, I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. For this skill, I'll need a barrier, which I'll place on the floor under the drainage mat. set of gloves. And I'm going to need a triangular graduate container. I want to extend the catheter tubing to make sure that it's coiled on the bed and the patient isn't lying on it and it's not hanging, but also that it's not hanging near the floor where somebody might get their feet tangled up in it and trip or accidentally rip the catheter out. This catheter looks like it's in the appropriate position. We'll now remove the port from its protective sleeve on the bag. Sliding it out to the side will open the port. We can now position this open port over the graduated container and tilt the bag slightly to the side to allow the contents to drain into the graduated container. While doing so, we want to be careful not to allow that port to touch any other surface. Once the urine bag has been emptied, we'll slide the port back to the side to close it and very carefully insert it back into its protective sleeve. We want to make sure that the bag is hanging on a non-movable part of the bed and it's not touching the floor. We can now fold the chunks over the graduate container for safe and secure transport to the patient's bathroom. Once we're at the patient's bathroom, we're going to set the graduate container down on a barrier on a flat surface and position it so that we can read it. We need to be at eye level, and we're going to round to the nearest line, either up or down. You can see that the urine in this container is nearest to the mark of 425, so the amount that we will document is 425 milliliters, or cc's. Once we've measured it on a barrier on a flat surface at eye level, we can now empty the urinary graduate container. We'll throw the barrier away, open up the toilet, and we're going to dump the contents of the graduate container into the toilet. Now we're going to rinse the graduate container. We'll deposit the rinse water into the toilet as well. Now we can clean. After dumping the rinse water into the toilet, we'll set it down. Use a paper towel to pick it up. Paper towel to dry the outside. A paper towel to dry the inside. Let's part this and then one for the floor. We're going to place the graduate container in the bottom drawer and close the drawer with the paper towel. Okay, now I'll throw the paper towels away and remove my gloves. We'll throw those away as well. Thank you very much, Ms. Jones. Is there anything else I can get for you while I'm here? A magazine, perhaps? You have your call light there. If you should need anything at all, please feel free to let me know. I'm going to open your curtain, wash my hands, and document my skill. Thank you. After washing my hands, I'll document on the intake and output sheet that the evaluator gives me. I'm going to document the time of output, the type of output, which is urine, the amount of output in cc's, and my initials. After documenting, I'll review the steps of my skill, make any corrections, and then tell the evaluator my skill is done.
Can you grab the light for me, please? All right. Any questions? Oh, gosh, that is great. Any questions on those two skills? Pretty easy, right? Okay. For the test, they are going to tint the water yellow, but it is water. But they will tint it yellow. If it's clear, it's too hard to read. And those evaluators actually have to see how much urine is in the cup. So when you get down at eye level, the evaluators are going to be a little ways away, and they're going to be reading it as well to see how close you are. You can be off by 50 cc's in either direction and still be accurate. That's a huge amount. Okay. Good. Did I get you fast for anybody? Is anybody lost? No? How do you feel about the class overall? Do you feel more comfortable with taking the test?
I would say so.
Okay. Page 142 of your white book as a practice test. Some of you have probably already taken it. Most of you didn't even know it was here. This is a really good indication of how you're going to do on the written test for the state exam. Most students tell me that my test is a little bit harder than the state exam. The answer key is in the back.
You see how many numbers there are to it?
There's 60 questions. It's just like the state exam. So it's 60 questions, multiple choice, the type of questions, the way they're written, the content that the questions have, it's very similar to the state exam. Very, very similar. So this is going to help you kind of find out whether you're ready for that state test. If you miss more than 7 questions on this test, I want you to take it between now and Wednesday. If you miss more than 7 questions, I need you to come see me after class or sometime on Wednesday. You need to get my attention. I'm putting this on you guys, okay? Because if you miss more than 7, you're not ready for the test. So it's going to be up to me to kind of figure out where your thought process is and to help you kind of redefine what the test is looking for. Sound fair?
I do have a question on the chapter 8 test,
Okay.
because I was a little confused, I think, about the feeding tubes. Because like as far as what CNAs can do, are CNAs not allowed to feed the patient? Okay, because I put that as one of my answers and obviously it was wrong, so
Yeah, CNAs do not do anything with feeding tubes.
they can only position
We can only position the patient.
the patient.
Right. Right.
So the RN would have to feed them because
Or
it's
LPN.
abnormal.
Yeah. Right. Right. Now, again, you can be trained in some places. The majority, the vast majority, feeding tubes are not a delegatable skill. There's one notable exception to that. If you are working with developmentally delayed individuals, these are adults that can't really live independently. So they usually are in group homes, people with cerebral palsy, advanced Down syndrome, severe developmental delays, that type of thing. Some of them will have feeding tubes, and med techs can be trained to give tube feedings in that population. But that's really the only exception that I'm aware of.
I'm guessing there are risks if you don't do it.
There are
correctly.
big risks. The biggest risk is aspiration.
That goes into their lungs.
Are the nurses supposed to allow a family member to do it, to feed someone?
Well,
and to clean the tubes?
Yeah, again, as a nurse, my primary job is education.
Mhm.
So I'm, teaching patients about their health conditions, families how to care. So yes, tube feeding is definitely something that a family member can do, or the patient can be trained to do it themselves. That's fine. But one of the things I have to do is make sure that they're aware of the risks involved and that they have a process to follow. And also that they're aware of what to watch for.
Yeah.
So they know what to report. But yes, I can train family members to care for a loved one or patients to be independent. Yeah. This is actually becoming a big trend. And I'm watching on my YouTube channel, I watch my metrics, and I'm getting a lot more people now on my YouTube channel that are watching my videos that are in the 65 and up age range. And it's primarily because they're now forced to take care of a loved one, and they need the skills to be able to accomplish that. Yeah, things are changing. Okay, I do have a quiz for you from today. Unfortunately, my printer ran out of ink, so I cannot print it. I do apologize, but I will give it to you on Wednesday so that you have it to go, with the rest of your class quizzes. I just unfortunately can't print it right now. So you don't have to take that practice testing class today. Just if you can do it before you come back on Wednesday, just to identify your own readiness. That's all it's for. I'm not going to ask you for the score. I will not ask you what, how many you missed or anything like that, like I do with the chapter test. It's just up to you to take the test, to grade it, and then to identify if you're ready. If after the taking the test, you do not feel you're ready, or you've missed 7 or more, you need to come see me. And I'll make sure that you are ready. My whole goal is to get you out there working. I think you all are going to make tremendous caregivers. And my goal is to get you out there working. But we got to get you through the test first. Remember, there's 5 main things they're going to grade you on. Want me to go over them again?
Yeah, I want to write them. Please.
Know your role. And that can be summed up: care plan, the whole care plan, and nothing but the care plan. So know your role. Know your normals. Because remember, a good part of our know your role is to report and observe and report. So we have to know what's normal. Patient rights. Don't treat adults like children. Safety. And infection control.
These are like the 5 main things on the test that they're looking
Yeah. Now, if you combine that with this poster over here, you remember this poster? It's the care plan, the whole care plan, and nothing but the care plan. The CNAs do normal. Principles, remember all of these things, guide our performance, tell us how to do it. It's always about the patient, and we report everything to the RN. If you remember that, that is CNA right there. Everything you've learned falls into that one of those categories. Everything you've learned. I just redesigned the badges you guys got, the little student badges. I just redesigned those. They'll be here next week, so the next class will have them, but I put that on the back. So you've always got it with you. My special talent in the world is to take complex subjects, find common themes, and break them down so they're easy to learn and remember. That really is my superpower, is to be able to take very complex things and make them easily repeatable. And that's why I come up with these, because it makes it easily repeatable. I'm going to, so you guys know I go live every Thursday on YouTube. I'm starting, this is going to be really hard for me, but I'm going to develop a TikTok channel, because I have a virtual assistant that starts in 2 weeks, and I'm going to be doing skits Connie, the crappy caregiver. And you're gonna see her, she's gonna have a little thought bubble, what would Miss Patty do? And then one of my principal, and then I'll be talking about one of the principals. So, yeah. So all the things you shouldn't do, all of the, the things that maybe you're thinking, thinking is bad, you don't think. Making decisions on your own, not following the principles, like not using a barrier at the table, or not covering the patient, or not talking to the patient. So I'm going to be doing all of these little skits and then to illustrate these principles. So if you're on TikTok, watch for it. Watch for me.
Sounds you on my free page.
Yeah. And hopefully I can make them fun and entertaining. And yeah, I'm getting like a little wig and big glasses.
Oh, you're gonna be Connie?
I'm gonna be Connie, the
Oh.
crappy caregiver. Yep. So remember in the very beginning, the very first day, I showed you CNA number 1, CNA number 2. Yeah, Connie, the crappy caregiver is CNA number 1 all the way. So that'll be fun. All right, well, I am officially done with you. I've taught you everything I can teach you. The rest of the class is practice. You're free to stay and practice. If you need anything, please let me know. Please bring your books back with you on Wednesday, your blue books. The white books are yours forever, but the blue books I will be collecting. We will take a photo. I've learned I have to tell you guys that, because otherwise people get mad. We'll take a class photo. I do post it on Facebook. I do not tag you. So you have to go to my Facebook page and share it yourself if you want other people to know. It's right up there. It's for your CNA. I'm branded everyone.
Could you be able to email it to somebody's email account if you're asked to?
Yeah, just write down your email address for me. It'll take, give it to me on Wednesday. It'll take me a little bit of time to get to it. Yeah, I will. And I have a folder for you that I'm going to be giving you on Wednesday as well that will kind of take you through from graduation on. So we're going to talk about continuing education, renewal requirements, finding a job in healthcare. It's a little different than other industries. So we got a lot to talk about on Wednesday, but we will have graduation. You will have some practice time on Wednesday as well. So congratulations to all of you. You survived.
You can say congratulations when we pass the test.
I'm hoping that you guys do let me know. You've got my email address on your syllabus. You've got all my contact information on Popple. You know, if you need to scan that QR code on the tables again, you can. But send me something. Let me know that you guys have passed. I really do like to know how my students are doing. A lot of people take the test and then they just go and they forget to come back and tell me. It's like, I want to know too. I'm invested. Then they'll come back like 6 years later and say, oh yeah, I'm an RN now. And cool. So I guess you passed.
Probably be coming back for our scrubs.
Yeah, a lot of people, but I'm not in the store that much. Not as much as I used to be. Going to be in there even less now. Jake doesn't know it. He's going to have to fit. But I'm going to be in there even less now because I've got to get the, I'm writing 2 books and I've got to get them done because I have to go to print. So I'm trying to get those finished. I have 3 weeks off between now and the next class. I'm going to be speaking at a state conference in 2 weeks to health science educators. So that's going to be a really big conference. And I'm going to be speaking nationally in November.
You're kind of a big deal.
A little bit. A little bit. I'm getting more national speaking engagements, and that's I didn't think I was going to like it. I mean, because I'm okay with you guys, you know, I mean, it's a small class, yeah, I get to know you, you know, we become friendly, But when you're, looking out and there's like hundreds of people and they're all RNs, and they're all instructors, and everybody has their own thought process and way of doing things. And, you can get pushback. You can get people to challenge you. So it's a little intimidating, actually, but turns out I love it. Who knew I liked public speaking? If you went back and told my high school me, she would have laughed at you.
Is there gonna be someone coming in to speak as well on Wednesday? You said there was like a company or something.
Yeah, I've got like 2 or 3 that had asked, and to be honest with you, I don't think I got back with any of them. So let me send some emails today. I'm glad you reminded me. Let me send some emails today and see who's gonna be coming in and speaking. Everybody wants you. Oh my gosh, everybody wants you.
I was surprised. I went on Oak Hill and they weren't hiring for CNAs. The other hospital, Rivera.
Yeah,
down-
Brooksville is, yeah.
But I was surprised Oak Hill was not.
Oak
Or it
Hill,
wasn't on the
yeah,
website,
Oak
I
Hill is, but they don't have any positions posted right now. And the reason is, so Oak Hill is kind of sabotaging me a little bit. Oak Hill contracted with me to be able to use my book and online program for training. So they just had a class that started in Hillsborough County. Now it's my program. And it's all over the country, but they weren't supposed to really be in my geographic area. Well, they just started a class in Hillsborough.
So like St. Pete.
Yeah. And they've got 60 people in that class that are basically it's for all of our geographic areas. So
Wow.
they're not posting because they're going to be pulling from this class. So we kind of sabotaged ourselves inadvertently with this. That doesn't mean that there won't be positions. There will.
Yeah.
So the only good thing about a recession, and it does look like we're heading toward a recession, but the only real good thing about a recession is that medical is one of the few industries that the hiring is generally not affected by a recession.
There's always a need.
Yeah. So that's kind of a good thing about being in medicine.